Hello.
Hello, doctor.
Hi, how are you?
Very well, thank you.
Great.
What about you, doctor?
All good, all been well. Thank you very much for asking. So how are you guys finding the course so far? There were any concerns or any comments they would like to say? Hello.
So far, it's a good course.
Okay, that's great. Are you doing questions at all? Are you doing any questions from any source, or are you just following up the materials that we share with you? Okay, so let's see how many do we have. So we have 5 so far. Abdullah. So yeah, hello everyone. It's Abdullah here. I think we've met twice before, and in the previous 2 sessions, emergency and critical care, and the other one was in the pharmacology and palliative care. So today I'll be explaining to you the infectious diseases and also the epidemiology. So both of them, in infectious disease, to be honest, you will have loads of questions coming in the exam, specifically the sexually transmitted infections and human bites and cat bites and many other things. So this is kind of a special topic that you need to completely focus on it, and it's guaranteed in the exam. So if you just go through the notes, you will be able to tackle each questions individually. So the second part would be the epidemiology, and as always, epidemiology is just a very short topic. You might have 1 or 2 questions in it in the exam. I wouldn't say it's significantly important, but it is guaranteed marks that you can easily get in the exam. Following this, we're going to have a few questions, and these questions will be about mainly the infectious diseases part. Okay, and so let's carry on. If you guys have any questions at any time, just you can jump in, open your mic, and just let me know, because I'm not on the Zoom at the moment. I'm just on the GoodNotes, which is explaining to you from. And also, if there is any technical issue in terms of the internet or the screen sharing or whatsoever, just send a text on the group or a private message to me in WhatsApp. I have my phone in front of me, so I'll be able to pick it up quickly. So we're going to start by giving you a few examples of some kind of important diseases, and we have this lovely table that is summarizing everything. So believe me, if you have like each thing like separately, it's going to be like very difficult for you to remember, and you don't need like to spend so much time in remembering these things which you will never meet in your practice. I wouldn't say never. You will meet in your practice, but rarely meet in your practice. The table is amazing, and it is very short and to the point, and giving you what comes in the exam. So here, initially we have here the disease, and then the clinchers, or the main points that come in the exam, and then the organism, and you have here the treatment or the presumed treatment, and then finally the probable or possible complications. So number 1, we have Lyme disease, and number 2, we have scabies, and we have multiple things. So the first page, you have Lyme disease, scabies, and infectious mononucleosis or glandular fever or Kessing disease. Okay, glandular fever or Kessing disease, and we'll know why. So again, you have Lyme disease, and you have scabies, and you have infectious mononucleosis. So Lyme disease, you need to remember two things. You need to remember two things, which is this part. This is basically like everything you need to know about Lyme disease. So it's a face. So there is probable facial palsy and arthritis, which is joint pain, and then carditis, and which happens in camping trip as well. And finally, erythema migrans, okay? Erythema migrans, which means some red areas, which is erythema that happens all over the body, and it keeps migrating. So migrans means it keeps migrating from an area to another, and it usually starts in the lower limb or the peripheries and come to the trunk, from the periphery to the trunk, okay? So again, face, which is facial palsy, number one, facial palsy. Number two, arthritis, carditis, and camping. And finally, erythema migrans. And the treatment will be dog Amazon safari, okay? Dog Amazon safari, which means number one, doxycycline, number two, amoxicillin, number three, ceftriaxone or ceftriaxone, okay? Dog on Amazon safari. So camping should remind you of the word. So when you get a stem in the exam that mentioned that the patient was camping, so you think it's either Lyme disease or scabies as well, could be in camping. So it gives you an idea of what's happening. So in Lyme disease, the patient was camping and has an annular rash, which is target lesion that keeps migrating. So annular rash that keeps migrating. And the main causative organism is Borrelia. I don't know how to pronounce the second word, but I just remember how it looks like. So it's one of the spirochetes, and it is spread by tick bites. So the story is usually a family who went camping somewhere in the world, maybe Spain, maybe Thailand, whatsoever, and then the patient is presented to you 2 or 3 weeks after camping, with the whole family presented with some kind of rash that initially started in the lower limb and kept migrating until it reached the trunk, and presented to you with this kind of rash after the camping. So you think that this is probably a Lyme disease and you need to treat it. So doxycycline, if it is an early disease, which probably first 2 or 3 weeks, and amoxicillin is an alternative. It's not like we don't give all of them all together. It is an alternative to doxycycline if doxycycline is contraindicated, and mostly doxycycline is contraindicated in pregnancy because it causes discoloration of teeth. This doxycycline causes discoloration of teeth to the the fetus, okay, and also in children below 8 years. So it's completely contraindicated. So this is when you need to give amoxicillin instead of doxycycline. Ceftriaxone, if the patient is cardiac or CNS, and you're very lucky, C, C, and C. So if the patient is cardiac or CNS, you need to give ceftriaxone instead of doxycycline or amoxicillin, all right? So the probable complication, which is facial palsy, meningitis and encephalitis, and arthritis, okay? Meningitis and encephalitis and arthritis. These are the possible complications which happens from the Borrelia or the spirochetes. So number one, again, is Lyme disease. So guys, to be honest, infectious disease is basically about memorization because you're just finding a disease. So Lyme disease is a patient who went camping and presented to you with ring lesions or erythema migrans, and sometimes a bit of pain in the joints and probably facial palsy, maybe CNS complication, maybe carditis, and the treatment for that is doxycycline. And if not possible to give doxycycline, if it's a pregnant female or a child less than 8 years, you can give amoxicillin, and if the patient is CNS or cardiac, you can give the ceftriaxone instead of all of them. Number two, you have scabies. So scabies.
Sorry, what was T standing for after
Sorry?
face? What was the triple T standing for after face?
Treatment.
Oh, sorry. Thank you.
Yeah, it's treatment. I know it's not, you're right. I'm from Egypt, so we were usually using this. And in like medical school. So a few days ago, I was actually using it between the chat between myself and one of my consultants, and he asked the same question: what is triple T? So yeah, that's absolutely fine. It's treatment. Okay.
Yes.
Okay. So number 2 is scabies. So for scabies, you have an elderly female or an elderly male who lives in a nursing home. So guys, I mean, these kind of words and camping as well, it's not necessarily that it's like the only thing that it attached to the disease. We're just giving you like an idea. This is normally the scenario. This is usually the scenario. This is there is a high possibility that the patient will be camping, they will get Lyme disease. But sometimes the patient are not camping. They're just, for example, they came somewhere in the world, maybe South America, maybe in Africa, probably, or any of the tropical areas, and they just live there. I mean, and they got the disease. But I mean, it just, you know, it was just giving you the clenchers that will direct you toward this diagnosis. So for scabies, it's caused by Sarcoptes scabii, and this is some kind of worm that goes into the skin. So let's say if this is your skin, it will start to live just under the skin and will make like an exit from the skin, which is called burrow, right? This is from its pathophysiology. So this is going to be very itchy, specifically after taking a warm shower. This is a typical presentation, and it will be very, very itchy at night as well. So basically, it is itchy when your body temperature is lower. So following a bath or following a good night's sleep, it usually happens in all your flexures or in the flexor surface. Yeah. So for example, it happens behind your knee. It happens as well on the elbow. It happens in the neck. It happens in probably the buttock area. So it could happen in all your flexors, right? Or flexures, sorry. So what is your presentation? So you think about an old female who lives in a nursing home, presents with very bad itching all over her body, specifically after taking a hot bath or at night. And you look at her flexures and you find that there is some punctures in the skin with burrows, and sometimes even the Sarcoptes scabii is coming out from it. All right. So these are scabies. So what is your treatment for scabies? It's not only, to be honest, it's not only this. This is not only the treatment, this is the medical management, the medications that you need to give to the patient. However, Sarcoptes scabii is something that is very contagious, and it remains on the bedding for so long. So you need to discard everything. The room needs to be completely like discarded. I mean, you need to get rid of the sheets, the bed sheets, and even the clothes, and wash it with really hot water, maybe boiled water, up to 100 degrees, and keep it in a plastic bag in the sun for maybe a few days or even up to weeks. But the treatment for the patient include number 1, permethrin 5%, which is the first line of treatment. And number 2 is malathion 0.5%. This is the second line. And also you need to focus that, let's say a patient had Sarcoptes scabii and they live with a family of 5 members. You need to contact the 5 members and start treatment for all of them, even if they don't have any kind of symptoms. You need to start the treatment for all of them. You need to give them the clinical advice. And by the way, I got this station in my PLAB 2 exam. Okay, it wasn't PLAB 1, it was PLAB 2 exam. And I had one of the family members who presented with Sarcoptes scabii or scabies. So what are we going to do? So you need to discuss your management plan with them. And the management plan will be, let me bring you a better paper. Move the trash. Sorry, guys, I'll just bring a better one. All right, so what's your management plan? So guys, this is a very common, question in practice, to be honest. And also in PLAB too. So management plan, it doesn't mean that you're only giving medication to the patient, right? So medication is just one part of it, okay? But there are many other things that you need to do for the patients and to cater your management, based on every patient. So there is, number one, any management plan, and generally, I'll give you a schematic approach. So number one is non-medical, all right, non-medical and medical management, right? So this non-medical thing, it could be either social, for example. It's good, like, let's say you have a psychiatric patient, they will need some kind of social support, and the NHS can offer this as well. It could be a change in risk factors, right? If the patient has certain, and we're going to discuss this later on, certain risk factors for, let's say, the patient is at higher risk of developing myocardial infarction. If you remember the glucose last time, which I mentioned to you. So if he is diabetic, for example, you need to control his diabetes, and the hyperlipidemia, you need to ask him to stop eating lots of fat. Let's say he's obese, you will ask them to lose weight. So all of these are non-medical management, right? Controlling the risk factors is also considered non-medical management. And also, if you have any kind of environmental factors, if you have any kind of like hygienic factors, you can include loads of things under the non-medical. And medical, it could be purely medical, right? Which is medical treatment, or surgical, right? So are you doing any surgery for this patient, for example? And surgical, is it an invasive surgery, or is it a less invasive surgery, or just a procedure? And medical could be non-pharmacological, which is not giving medication, but still it's a medical management. Let's say a patient has benign positional vertigo, for example, or benign positional paroxysmal vertigo, which I would assume we're going to explain this in neurology. So you're going to do non-pharmacological management, which is some kind of the Epley's maneuver, right? So this is non-pharmacological, but still it's a medical management. And finally is the pharmacological management. So this is your scheme for any kind of management plan that you need to make, all right? So let's apply this to scabies, right? So in scabies, you need to do some kind of non-medical management. What is a non-medical here? So you need to tell your patient that all the families need to come and visit me. Number one. Number two, you need to get rid of all your beddings. You need to clean all the house. You need to do this and this and this. And also there is an NHS leaflet that you need to give to the patient about the scabies, right? And then, so this is the non-medical management, which is risk factors and so on. You need to avoid traveling. You need to avoid contact with other people. You need to follow this kind of hygiene. And then you need to medical management. Mostly here is going to be pharmacological, which is malathion, or the other medication, which is the permethrin. Yeah. So are there any possible complications that happen from scabies? Yeah, there is. If the patient has compromised immunity, like if they have HIV, or if they have any kind of AIDS, or any kind of things like immune deficiency disorders, there might develop something called Norwegian scabies, or crusted scabies, which is, a late stage of the disease, because the body is not fighting the scabies, all right? And they present with diffuse cutaneous involvement and the clustering and the very malodorous. It's the same thing, but it's more extensive type of the disease, all right? That includes the whole body and all the cutaneous area of the skin. Last one on this page is the infectious mononucleosis, which is caused by something called Epstein-Barr virus. And I need you to count with me, all right? What I would like you to count is human herpesvirus type 4, okay? Human herpesvirus type 4. So we have like 8 human herpesvirus. We need to keep counting them, and knowing them is not very relevant to the exam, to be honest, but it's kind of interesting to know the human herpes virus. So this is number 4, is Epstein-Barr virus, and patient is presented usually with pruritic rash, possibly after penicillin. I mean, it's not typical, but sometimes it's having infectious mononucleosis. This is basically a lymphatic disease that leads to a generalized lymphadenopathy all over the body. But the most apparent one is the cervical lymph nodes. Sore throat, it's again, your tonsils are swollen, and tonsillar enlargement as well, and also palatal petechiae and splenomegaly. So basically, it is generalized lymphadenopathy. So what is that? It is the cervical lymph node enlarged, the exudative tonsillar and sore throat. This is from the enlarged tonsil as well, and the splenomegaly, which is again the generalized lymphadenopathy. Okay, so how you diagnose this? There is something called a monospot test, or pole Bunnell test, or heterophil antibody test. You mean you don't need to know what's happening in that test? It's just a test that you order, and the lab team will be doing it for you, and it diagnoses the virus, which is the Epstein-Barr virus. You can do a PCR as well for the Epstein-Barr virus. You can do ESR and white blood cells, and the patient will have lymphocytosis. So as I mentioned, this is a lymphatic disease, and there is anemia as well, which is a cold agglutinin. So there, anemia is like a very late condition that happens with infectious mononucleosis, because this virus starts attacking the white blood cells and attacking the red blood cells as well. What you need to do is basically supportive management and watch out for, some kind of a significant complication, which is called the splenic rupture, because the spleen will keep enlarging, and there is a risk of rupture, specifically in immunocompromised patient. So you will watch out for this, and you start treatment with basically supportive management. So basically, if the patient is dehydrated, give them fluids. If the patient is in pain, give them analgesia, and so on and so forth. So this is our first page. Does anybody have any questions so far? So we discussed 3 things in the first page. Guys, if you have any questions, just jump in. The 3 stories here was, number 1, a Lyme disease, and number 2 is infectious mononucleosis, and number 3 is the scabies, right? If you want to know a story, so Lyme disease, a family went camping, and they presented to you with a rash, which is raining and migrating, okay? And it started initially in the trunk, and it reached to the whole body. And then this family presented to you with this, and if there is any of this family that is immunocompromised, there is a risk of meningitis or risk of encephalitis, and there is also a risk of carditis, and a risk of arthritis, and a risk of facial palsy, right? And a risk of facial palsy. So all these things you need to treat, number 1, by doxycycline, unless the patient is one of 2 things, unless the patient is pregnant or a child less than 8 years, you need to give them something called Comox-Clav. And if not, if you can't give this treatment, you can go to the 3rd line, which is ceftriaxone. So it's Amazon Safari, if you remember. So amoxicillin, sorry, this is amoxicillin or Comox-Clav, doesn't really matter, to be honest. So dog Amazon Safari, right? That's your treatment for Lyme disease. Scabies, we know the medical and non-medical treatment. Usually a female, old age, live in a nursing home, presented with itching, basically at night or after taking a bath. And then there is a lot of burrows in the flexures, right? And this burrows probably will have the Sarcopsis scopii coming out from it. How would you treat that? So basically, we mentioned the medical and non-medical management. And we know the first line is permethrin, second line is malathion. And the 3rd one, infectious mononucleosis, this is a lymphatic disease. So basically, needs supportive management. And watch out for one thing. So the spleen will be very large, it might rupture, and the tonsils will be very large, it will cause sore throat, and the cervical lymph node will be very large. Basically, all lymph nodes will be enlarged. I assume that you don't have any question on that, so, but please, if you have any. Sorry?
In mononucleosis, that without supporting treatment, with or without, would you get the splenomegaly, or how likely is that to happen? Well, spleen rupture, sorry.
Splenomegaly is very low risk to happen, and I mean, splenomegaly will happen, but splenic rupture is very low risk to happen. But splenomegaly will happen, and it will improve after. I mean, the virus is called one of the dormant virus, so if you have it, it will stay there, but it's not causing you any issue. So it will be there anyway, but it's not causing you an issue. The splenomegaly will happen gradually, will take loads of years until it happens. And if it happens at the end, you can do splenectomy. It's like really significant splenomegaly, right? If the tonsil is significantly high, you can even do tonsillectomy, which is absolutely fine. If the cervical lymph nodes are very enlarged, and I mean, I'm not expecting that the cervical lymph nodes will be significantly enlarged, that it's causing any serious issue. But if they are enlarged, just leave them there, or take a biopsy or something like that. So it's basically supportive treatment. You're not actually doing anything for the patient. But you need to be focused because, I mean, to be careful, because the Epstein-Barr virus is serious in two scenarios: the splenic rupture, and this is an acute abdomen. And there is actually another scenario, which is the Burkitt's lymphoma, okay? The Burkitt's lymphoma, but there is no actual treatment for the virus itself. You can't get rid of the virus, right?
Yes.
Okay. Necrotizing fasciitis, this is a very serious and a very important and very rare as well. I mean, I didn't practice medicine for so long. I've been practicing medicine for 4 years now. So I've seen this only once in my life. And I worked in orthopedic in King's College for 1 year. That wasn't that year. So it's a disgusting disease, to be honest. It's really, really bad necrotizing fasciitis, this thing. So what happens in it, it's basically one of the patients, let's say, had very simple infection by a very weak bacteria, which is a staph, for example, or streptococci. Most of the time it is strep by staph and caused it as well. And that happened, let's say, in his lower limb or her lower limb, or happened from a surgical wound, for example. And then this bacteria started to creep just below the skin and caused, like, I mean, suppurative substance just below the skin in the whole limb. It specifically happens in patients who are diabetic and who are immunocompromised. And the patient will be presented by very significant pain in that limb. And you look at his skin, the skin looks absolutely normal, but you can sort of palpate the limb. You will find it's very indurated and very painful, and the patient cannot tolerate it. The patient will be presented to you in a very septic condition. He's having like septicemia, basically, or even sepsis. And what you need to do is you need to basically do the debridement of the wound and take all the infected area around the muscles and in between the muscles. And sometimes it happened, I mean, up to even amputation, you know. So it's a very serious disease. So again, it probably happens from a surgical wound or after injection for IM or IV, if you're not very clean while injecting this. It most probably will happen in the immunocompromised patients or the diabetic patients. The patient will be presented by very severe pain that is disproportionate to the physical sign. So the pain is severe. When you examine the patient, the skin looks normal, the leg's not very swollen, and there is no response for antibiotic. And sometimes it falls poly or indurations in the skin, and from intense anesthesia-like pain. So I mean, the pain will be in the lower limb, but the patient cannot like feel the sensations in the lower limb at the same time. The commonest organism is a streptococci. You need to do a surgical debridement, an IV fluid, an IV antibiotic like clindamycin, benzyl penicillin or any antibiotic who works in the streptococci. However, guys, in the management here, when you have this question, let's say in an interview or in PLAB 2, you need to follow the A, B, C, D, E approach, which we mentioned in the emergency and the critical care scenario, because this is a life-threatening sepsis, and you need to do the sepsis approach, which is take 3 and get 3, if you remember what we've talked about before. Following this, we have a chicken pox, which is disease that happen basically in children, it's caused by a virus called varicella zoster virus. Varicella zoster virus, and basically it's an airborne infection, so or a direct contact infection. So it can happen from both. So it's either airborne respiratory droplets, or it happens from direct contact with vesical fluid. So what happens is, if you have the varicella zoster virus and you sneezed in front of a child in a school, or anywhere like confined area, so they'll probably catch this virus from their nose or their mouth, and they will be presented by initially by some kind of macular rash that starts basically in the trunk, and this will start increasing gradually until the macula become papula, which means increasing in size and slightly raised, and then this papula will form a poly or a vesicle. So this vesicle will be fluid filled, and then this vesicle will start to open, and after opening, the fluid will be coming outside. And if you came in contact with the patient at this stage, you will get infected easily, and that's why these patients need to use their own towels. We don't share towels for this particular reason. There is also pyrexia, or increased body temperature, and finally there is lymph node enlargement as well. It's very itchy at the time of the presentation. Probably this chickenpox virus, you had it once in your life at least, and if you hadn't have it before, that means you are at higher risk of getting this, and when you get it as an adult, it's very severe. Your treatment for that is basically supportive treatment. You need to take to keep hydrated, adequate fluid intake, and avoid scratching to avoid secondary bacterial infection over this area. The analgesia and antipyretic, maybe antihistaminic as well to avoid the itching. And finally, if needed, we can give the varicella zoster immunoglobulin cyclovir. And I assume this will be explained in the pediatric section in a bit more detail. So chickenpox or varicella zoster virus, it's caused by chickenpox, it's caused by varicella zoster virus. And it's mostly happen in the children, and it's once in a lifetime. Once you had it, I mean, most probably won't get it again. And it starts with a small macula, and macula is a patch that is less than 1 centimeter, and then the macula will be papula, which is slightly raised, and the papula will be fluid filled, which is a vesicle, and the vesicle will rupture, and after rupturing the vesicle, you get the fluid out, and if you came in contact with that, you are at higher risk of infection. And so this is a varicella zoster virus. Your lymph node around it will be enlarged lymph nodes, and it happens all over your body, but basically in the face and the trunk. This is the main area that happens. The question that comes in PLAB 2 is, does the patient need to stop going to school? Yes, they need to stop going to school in this stage, in the infective stage. And this duration takes normally 7 days. You don't need to treat the patient unless they are immunocompromised. All you need to do is to do supportive management. And this supportive management includes giving fluid, analgesic, antipyretic. I mean, whatever the patient has, you can treat the symptoms. Toxoplasmosis, which is one of the torch infections that you do the test for the pregnant lady just before pregnancy. So toxoplasmosis is a very dormant disease that caused by Toxoplasma gondii, which comes from cats, basically the cat feces. Well, you don't really have symptoms from toxoplasma unless you are immunocompromised or you had very extensive kind of infection. So one of the things that we need to mention here, and we're gonna mention something in detail about it, if CD4 is less than 50 in an HIV patient, you are at very high risk of having toxoplasmosis. However, there is multiple values, and this is very important, by the way. If the CD4 is less than 50, you are at risk of toxoplasmosis. We'll mention multiple values at the end of the session about what is the level of the CD4 and what are the risks that you have for having certain diseases. All right. So the patient will be having probably a worsening headache and facial weakness, visual hallucination and pain, and the brain mass lesion. So basically, what I would say is this patient will be having a tumor-like symptoms, brain tumor-like symptoms, right? So what does it mean? It means they have a mass lesion inside their brain. So they are at high risk of, it's exactly like tumor, right? So they'll be having headache, visual hallucination, confusion, and also probably seizures, neurological deficit like motor or sensory deficit, and like anything like that might happen for those patients. If you get an MRI, you'll find something called ring enhancement, but you need MRI head with contrast. You will find ring enhancement lesion. So the lesion will be like this, and the enhancement will be from the outside. I'll show an image now. And treatment is, if needed, and I would say in most of the cases needed, an immunocompromised or pregnant woman, and it's going to be pyrimethamine or sulfadiazine. So meningoencephalitis is one of the complications, or myocarditis is one of the complications, right? So again, toxoplasmosis is a high risk in patients who have CD4 less than 50 for HIV patients, and the causative organism is Toxoplasma gondii, and also patient will be presented by brain tumor-like symptoms, and this include worsening headache, facial weakness, visual hallucinations, and probably any kind of neurological presentation like confusion or seizure or any kind of neurological deficit. It's either sensory or motor. If you get an MRI with contrast, you'll find that multiple ring enhanced lesion, and you treat if the patient is immunocompromised or having neurological symptoms, and treatment is pyrimethamine or sulfadiazine, right? So this is basically the Toxoplasma gondii. Let me show you a picture of the MRI contrast for Toxoplasma gondii, right? Toxoplasma MRI. Yeah, this one is ideal. So it's basically, this is how it looks. So this is a ring enhancement lesion for cerebral toxoplasmosis. So multiple lesions with ring enhancement from the outside. Any questions on page 2, guys? Okay, can you let me know if you're still here?
No, it's all right.
No questions, right? Okay, I'll ask you a question. Can let me pick a name from you. Can Abigail, please?
Yes.
Yeah, I can ask you, what is the first line of treatment for Lyme disease?
It's doxycycline.
Yeah, excellent. And what is the contraindication of doxycycline?
Children.
Below than 8 years, and what else?
Pregnant women.
Yeah, pregnant lady for blackening of the teeth. Excellent. Okay, Abdullah.
Yes.
What is the first line of treatment? And let me think. Don't look. What is the treatment for scabies? If you can mention the first line of treatment is scabies.
Scabies,
Yeah.
permethrin 5%.
Yeah. And what else?
And there is also methalion, I think, methion.
Malathion. Okay, fine. All right. Yeah, that's fine. Thank you. Let's move on to the next page. And the next page we have mumps, or paramoxovirus. So mumps is, I mean, it's for personal interest. You need to be careful about mumps, because it's like it's a disease that usually happen in schools, or happens in let's say accommodations. Basically, if you live in a shared accommodation with other people, so there might be like a small outbreak in these areas. And mumps is, you need to think about it, that parotid gland will be affected, and your pancreas will be affected, and finally your testicles or ovaries will be affected, right? So let's talk about it. So paramoxovirus is the main reason, and it's a general infection signs, which is like, I mean, malaise and vomiting and headache, and feeling very tired and so on. And there is also as well parotitis, which is a swelling of the parotid gland and some signs of inflammation in the parotid gland, and also the pain and the pain and the swelling is basically bilateral on the parotid gland, which is basically at the jaw angle. And this is a highly infectious disease that is basically transmitted by droplets from your saliva. So if you sneeze in front of someone, you will basically transmit this disease. There is very severe complication or very important complication, which is the orchitis, which happens in probably up to 2 to 5% of the mumps, which is pretty high, from the 4th to the 5th day, and the scrotum will become very swollen and edematous, and the testicles will be impalpable, and usually it's unilateral and maybe bilateral, and can lead to infertility. And also pancreatitis is one of the possible complications as well. However, this is a self-limiting disease that only needs supportive management. Schistosomiasis, there are 2 different types of schistosomiasis, which is Schistosoma hematopium and Schistosoma mansoni. So hematopium, hematuria, mansoni is GIT. Hematopium is hematuria, mansoni is GIT, right? So you need to remember that hematopium is hematuria, so it's for the bladder, and it's common in Egypt. I mean, used to be common in Egypt and Africa. And the symptoms, I mean, it's very chronic disease, and sometimes the GIT one might lead to hepatomegaly, and might lead to esophageal varices, and might lead to severe upper GI bleeding. All right. In the past, we have like a famous singer from Egypt who died from schistosomiasis back in 70s. So X-rays will show a bit of calcification in your urinary bladder, and the ESR level will be very high. The eosinophils will be high in the FBC. You make an ultrasound for the kidney, you probably will find hydronephrosis. You make an ultrasound in the liver, you probably will find in the Mansoni type. Treatment is single dose of praziquantel. Single dose of praziquantel can treat you from schistosomiasis, which is really nice. However, you need to be aware of some possible complications. We mentioned the hematopium, hematuria, and squamous cell carcinoma of the bladder is common from this one. And again, we mentioned that the kidney might be enlarged in ultrasound, hydronephropathy, and even hepatomegaly or variceal bleeding is one of the important complications as well. So Whipple's disease, before we explain Whipple's disease, we need to explain what happens in your absorption, gut absorption. Let's say this is your gut. So you basically have a muscle wall, I mean, multiple layers, and payers mesh and so on. And you have here villi, and these villi is very like long, and it helps in absorption. So basically the food will be absorbed all the way in, all the way in, all the way in, you know, like all the way. So it increases your ability to absorb the food that you basically eat. However, in certain patients, these villi become very stunted. It's just like that, very short, just like this, right? So what happens when the villi becomes very short like that? So what happens is your ability to absorb will decrease. And if you're not absorbing your food well, you will lose weight, all right? you will lose weight, and you will basically probably have diarrhea as well. And I mean, you will have significant complication for like delayed wound healing for the vitamin deficiencies, malabsorption like starvation, pancreatitis, a lot of possible complications from Whipple's disease. However, what caused Whipple disease? It's a bacteria called Treponema whippeli, or Tropherma or Treponema whippeli is the main disease. It causes malabsorption syndrome and probably arthalgia, which is mainly in the peripheral joint and happens in middle-aged white man from Europe. If you take the jejunal biopsy, you will find mentioned here, stunted villi in the lamina propria will be filled with lymphocytes just in this area. Ceftriaxone is the main treatment, and you'll probably have systemic symptoms as a complication, which include cough and fever and enlarged lymph nodes. If cardiac involved will lead to infective endocarditis because this is a bacteria, so it can lead to septicemia, CNS involvement, dementia, ophthalmoplegia, and facial myoclonus. So this is Whipple's disease. Again, it happens in a middle-aged man. It causes a malabsorption syndrome due to stunted villi, and systemic symptoms could be cardiac and central, and cough and fever and enlarged lymph nodes. Brucellosis, it happens basically in farmers. So when you are exposed to the infected animal feces for quite a long time, or any kind of animal secretions, you are at higher risk of having brucellosis. The main presentation about brucellosis, which is very characteristic, is the andulant fever. And andulant fever, it means today you have fever, the temperature is like 38.5, and then tomorrow it's okay, and then you stay like normal for maybe 2 days, and then you have fever again, and then it's back to normal, and then again you have fever, and then it's back to normal, and so on. So this is andulant fever. So it's repeated episodes of fever that keeps recurring for a very long time, and you don't understand why you have this fever. So if you are a farmer who is dealing with animal secretions for a long time, so you are at higher risk of having brucellosis. I mean, it could be any of the animal secretions. Even milk is a secretion from animal, right? And you be presented by flu-like symptoms, and the bacteria is Brucella, and it happens through inhalation of these products or even contact. Incubation period is weeks to months, and it can remain for years. Doxycycline is the treatment, and rifampicin is the second line of treatment for those patients. So we've discussed here the mumps, the urchitis and pancreatitis as a complication. The treatment is basically self-limiting. That it happens in a school accommodation or any kind of accommodation. Schistosomiasis, that there is two things: hematobium, which causes hematuria and at risk of reflux nephropathy and squamous cell carcinoma. And that there is Mansoni, which is of the GIT and can cause hepatomegaly and can cause variceal bleeding. And the treatment is just one single dose of praziquantel. Whipple's disease, it happens in a middle-aged man. It's malabsorption syndrome due to stunted villi, and the treatment is ceftriaxone. And the complications could be cardiac or any other symptoms like infective endocarditis or cough or enlarged lymph nodes. You have a farmer who deals with animal secretions quite a long time, like let's say the milk or like any kind of animal secretions, or even the raw meat will be presented fever, which is fever over a very long period of time that comes and goes. The treatment is doxycycline and rifampicin. All right. So page number 4, and I'll ask you 2 questions after that. So leptospirosis, there is an Egyptian brand for tea, it's called Leptin tea. Leptin tea, I mean, it's the author for this notes. So, but I mean, it's an easy one to remember. So Leptin tea, it comes in red and yellow tags. So the patient will have red eye and jaundice. I mean, red and yellow, and the diagnosis is basically by blood and urine culture. You can diagnose the patient from those. So red eye and jaundice, which is red and yellow, that reminds you of leptospirosis, and blood and urine culture is a diagnosis. All right. So if the patient has history of travel or fishing or rowing contact with animal like rats, and represented by red eye, which is subconjunctival hemorrhage, and probably jaundice, and arthalgia and myalgia, which is muscle pain. How do you diagnose a patient with leptospirosis? And by the way, I had this question in my PLAB 1 exam back in 2019. So how do you diagnose those patients? There is a diagnostic test for that, which is serology, or getting the antibodies, which is usually present from day 10 from the illness. So it's serology, which is, I mean, you take some blood, or probably you can do that from the urine as well. Urine culture can grow the leptospirosis. It's usually detected in the urine after day 7 until a month. So guys, remember that, because in my exam, urine was not possible to take because it was before day 7. Because I mean, you can take it, but you won't find the leptospirosis in it. Usually the treatment is self-limited. Doxycycline is the first line of treatment. And for severe cases, you can give ampicillin or penicillin. Breast abscess, so how does it happen, or this breast abscess? Okay, so what is the commonest cause of an abscess? So Staph aureus is the commonest bacteria that can cause an abscess. So let's say if a female patient who is breastfeeding for quite a long time, the child keeps biting her nipples, and you probably have some Staph aureus in your saliva even. I mean, it's not necessarily to be there, but for any reason you have a staph in your skin and the bacteria started inoculation in this area, it will start forming an abscess inside the breast. So it will start initially by mastitis, which is basically pain and redness and swelling and hotness in this area, and the patient cannot breastfeed at that time because of the pain, the significant pain that she has. And then it will form an abscess here, and the treatment for an abscess is basically you start with antibiotic, and if it's not being treated with antibiotic, you need to do an incision and drainage of this abscess like any abscess anywhere else in your body. So breast abscess, it's an infectious mastitis, accumulated milk, allow bacteria to grow in the first few weeks breastfeeding of treatment. So the question here actually is, there's a question in PLAB 2 exam, is about what would the lady do? Will she continue to breastfeed, or will she stop breastfeeding? What do you guys think? Can anybody answer this question? What do you think? If a lady has an abscess, is she able to continue to breastfeed, or you will advise her to stop breastfeeding?
In mastitis, I think she can continue, but in abscess, I think she can't.
Why do you think that she can't continue breastfeeding in abscess?
Because of progression of infection, much more.
Well, so it depends. It really depends, and I mean, you're half right, to be honest. So if the patient has a breast abscess and you can tell that it's not connected with any kind of the, you mean the canals or the canaliculi that here that is taking the milk out of the her nipples. So if the abscess is not connected and you can tell that the milk is not like pussy, she can continue breastfeeding, or she can either continue breastfeeding from the other side. But if the milk, it looks like pus, she will need to stop breastfeeding. So it depends on in each case. But I mean, usually in PLAB 2 exam, you will mention to her the 2 options. Well, it really depends on the your milk. So if your milk is a bit pussy, and we can always investigate this and test your milk, and then we'll take it from there based on the results from the milk that we've taken from her. So if the milk has any kind of bacteria, so you don't need to give the child bacteria. But if it doesn't have bacteria, you can continue breastfeeding. All right. Any questions so far?
Yes, I have one question.
Sure,
But
go.
But the bacteria is not already dead. If it is already pussy milk,
Sorry, I didn't get that. Can you say again?
if the milk is contaminated with pus, but in pus bacteria is already dead, so how can it is harmful?
So you're saying if the milk is pussy, if it has pus, you will need to stop
Yes, yes.
breastfeeding. So no breastfeeding if the milk has pus.
Yes.
Is that your question?
Actually, my question is, what is pus? Pus is not bacteria which is already killed. So if it is contaminated with pus, still that milk does not harm the child because in it bacteria is already dead.
No, it's not necessarily that. I mean, pus is not dead bacteria. It's not necessarily that it is dead bacteria. You don't need to give pus to anyone. I mean, even if it's the child won't take pus, right? Because I mean, pus is not necessarily dead bacteria. It's just like liquefacted. So a few of the cells, which is the neutrophils, is not the bacteria itself. It has erupted and caused liquefaction of the membranes. So that's why it changed in color. But pus is full of bacteria, full of live bacteria, right?
Okay.
And this is why if you take some samples from an abscess and send it to a lab for culture, will it grow bacteria or not?
It might
Okay.
grow because it's living and dead, both bacteria.
Exactly, yeah, exactly. It will definitely grow bacteria. So yeah, so pus is not dead bacteria. I mean, even if it's dead, I wouldn't give a child pus, right? Yeah. All right. So
Anyway, the abscess would be very painful, isn't it? So the mother wouldn't be able to
well, you need to do
lactate the child, would it?
Would you
yeah,
give
but-
paracetamol or ibuprofen in that case, or it doesn't matter?
okay, good question. So like we mentioned before about the treatment or the management plan for anything, we're just giving you the, I mean, in this part, I'm giving you the very, I mean, short and very focused on high yield information. So let's say, how would you manage breast abscess? That's a different question. How would you manage it? All right. So we have basically number one is non-medical. What do you do in non-medical? So to be very painful, you will ask her to avoid tight bra. Okay. You will ask her to avoid significant mobility. All right. You will ask her to avoid milking of her breast. All right. And you will talk with her about the breastfeeding and give your advice like we mentioned earlier. So this is non-medical management of this patient. And also you will talk to her about the hygiene of this area and what to do. That's number one in non-medical management. Number two, in medical management, it could be purely medical, which is either pharmacological or non-pharmacological. So non-pharmacological, do you think we have anything here that is non-pharmacological for the management of this patient? I think it will be the same like we mentioned here. So nothing really that we can offer non-pharmacological. Pharmacological treatment, I will give her some supportive treatment, and this includes giving her analgesia. Okay. If she is pyretic, I'll need to give her antipyretic as well. If she is edematous in this area, I will give her anti-edematous as well, like alfentern and so on. And she needs antibiotic, obviously, right? And so this is basically the pharmacological or pharmacotherapy for this patient. I'll keep watching this for 2 weeks. And if the pharmacological treatment is not working, we'll go to the surgical management. And surgical management include incision and drainage. All right? Is that clear?
Yes.
Okay, great. So this is basically the management of a breast abscess. But here we just like mentioned to you, because this is what will come in the exam. What is the best antibiotic to give to the patient is fluorouracil. It's not going to tell you what is the management. It's not an essay question. It's a MCQ. Well, next is malaria, which is okay. Let me ask you a question before we go to malaria. Okay, so question is, what is the best test to diagnose disease? Confirmatory test. What is the confirmatory test?
PAS, acid shift tension with that.
I'm sorry, I didn't get your question or your answer.
PAS, acid shift, positive.
No. I'm asking about yeah, exactly. It's a jejunal biopsy. I mean, and you don't say biopsy only, because the answers will be number 1, duodenal biopsy, number 2, gastric biopsy, number 3, jejunal biopsy, number 4. You know what I mean? So you need to be very clear about that. So it's a jejunal biopsy. All right. Okay. Which kind of bacteria that we use monospot test to diagnose? Which kind of disease that monospot is used to diagnose? Anybody?
Mononucleosis.
Are you sure?
Yes.
Okay, great. So yeah, Paul, again, it's called Paul Bunnell or monospot test, so it's used in diagnosis of infectious mononucleosis. All right. Good. I'm happy with that. So let's move on to malaria. So malaria is usually present in travel to Africa, specifically the tropical areas around the equator. So the types of Plasmodium malariae, Plasmodium falciparum, Plasmodium vivax, oval, and I don't really know how to pronounce the last one. Okay, so Plasmodium falciparum, malariae, and vivax and oval, and the last one. The features, so basically, it's some kind of certain protozoa that enters the body, basically through a mosquito. And then it will stay in your blood, and it will start attacking your RBCs, and it will cause, disfigure or like a change in the shape of your RBCs. So it will basically cause anemia and a very high temperature and hepatomegaly, because they remain dormant in the liver at their last stage, something called hypnocytes. All right, hypno means asleep, because they remain dormant in the liver. It might cause some dark urine, which is called black water fever, and this is basically due to rupture of your RBCs. And if the RBCs rupture, the hemoglobin will be expressed, and they will come down in the urine. The urine will be really black, and it will cause black water fever, and myalgia and arthalgia and GI upset and jaundice might happen as well. So, so this is for malaria. So there is a severe complication for malaria. It's called cerebral malaria, which is impaired. Patient will be presented by like a space-occupying lesion like symptoms. So it would be impaired consciousness or any kind of neurological deficit. What is your investigation to diagnose is blood testing is mandatory. So you need to do a blood film. So this is the gold standard for the diagnosis. You need to look at the RBCs itself, and you will find like a banana-shaped protozoa inside the RBCs, which is called the plasmodium, or even like a ring form, a plasmodium on the Schaffer's dots. So it would be like that, and then it's either a ring or a banana-shaped. So it's like this. If you remember back from medical school, and it's dotted like that. Right. So this is how it appears on the blood film. And if the initial one is negative, you need to repeat it after 12 to 14 hours to 24 hours. as sometimes it's not detected in your sample. And if you have 3 negative samples, would make the diagnosis very unlikely of the reading it. But there is another test, which is a rapid diagnostic test, which is detects antigen and must be used as an adjunct blood films and not replacement unless the microscopy is unavailable. So again, the gold standard, and when I say the gold standard, very important for you to know. It means something that comes in the exam. It means something that is important for the diagnosis. So you need to remember that. What is the gold standard test for diagnosis of infectious mononucleosis? It's monospot. What is the gold standard test for diagnosis of malaria? It is the blood film, right? So you need to remember these kind of things. Rapid antigen test or rapid diagnostic test, it can be used if the microscopy is unavailable. However, the blood film remains the gold standard for diagnosis. Treatment of non-falciparum malaria. Non-falciparum malaria can be treated by something called chloroquine. Chloroquine is the drug of choice. Again, when I say the drug of choice, it's something that you need to remember, okay? Drug of choice is chloroquine for treatment of non-falciparum malaria. If chloroquine fails to treat or resistant Plasmodium vivax, it can be treated by something called quinine. Okay, by something called quinine. It is a second line basically. And for complete eradication, so primaquine is used for complete eradication of the non-falciparum malaria. Okay, so let's read some notes about that, and these notes came before in the exam. So malaria does not provide malaria prophylaxis. So basically in the UK, when you are traveling abroad or going to any like Congo or South Africa or any of these areas, you will need to take prophylactic doses for around 3 weeks before traveling to the areas in Africa, just to prevent or to decrease the risk of having malaria. However, this does not eradicate the risk, does not fully protect you. It does decrease the risk, but it doesn't fully protect you. It's used for eradication of malaria. However, before giving primaquine, you need to make sure that the patient does not have G6PD, because sometimes the patient have G6PD and they just don't know about it, and they are functioning absolutely normal. So you need to exclude G6PD because primaquine can increase the risk of having a G6PD attack, which is glucose 6-phosphate deficiency attack, and they will be very significant. Malaria prophylaxis in pregnancy. Guys, these questions are very important. Malaria prophylaxis in pregnancy is mefloquine. So we mentioned chloroquine is the first line of treatment of non-falciparum malaria. And if chloroquine fails, you can go to quinine. And primaquine is for eradication. And mefloquine is for the pregnant woman. Chloroquine and the proguanil are safe in pregnancy as well, but mefloquine is the best medication to give in pregnancy. Both types of malaria may produce, which is a falciparum and non-falciparum, produce 2 relapses of the blood and latent hypnocytes, which live in the liver because they are dormant there for a few years. And for this, you can also use a primaquine to eradicate. Covalent vivax have hypnocyte stage, maybe therefore relapse after treatment. Malaria is a notifiable condition and most commonly imported from tropical areas in Africa to the UK. All right. So this is for malaria. A quick recap for malaria. So you will probably have a patient who has been to Africa recently and presented to you with signs of anemia and very fatigued all the time and have muscle pain or myalgia. And sometimes they will have jaundice if it's so severe. And sometimes they will have arthalgia if it's so severe. And sometimes they will have black urine if it is so severe. And you see the patient, what is the best test to diagnose this patient? You will do a blood film for them. It will tell you about the presence of the ring falciparum, which is dotted by Schoffer's dots. How will you treat this patient? It depends. If this patient, if it is a female lady who is pregnant, you will give her mefloquine. If it's a young adult who's absolutely fine, you will need to do G6PD for them and then give them the chloroquine as the first medication. If chloroquine is not working, you can give them quinine. If quinine is not working, you give them primaquine for eradication, right? All right, so this is for malaria. Next question is about tuberculosis. Tuberculosis is caused by tuberculum bacilli, which is bacilli means it's like just like dots like that and has a membrane from the outside. So an infection which is caused by Mycobacterium tuberculosis, they commonly affect the lungs, and it is an aerobic bacteria, which means it loves oxygen, which means it lives because the lung has oxygen, and the highest percentage of oxygen in the lung is on the top. So it does not only live in the lung, but in the top of the lung. So this is the area where you will be looking for the presence of the TB focus or Ghon's focus. So initially it starts by presence of the bacteria right there, and the bacteria will cause chemotaxis to the neutrophils and all the kind of chemotactic substances, and this will be around it and then will form something called Ghon's focus, and it forms a membrane at the end. So TB, it does not only happen in lungs, the primary TB happens in lungs, but let's say if the patient is swallowed his sputum, there is a risk of having a GI, right? If the patient is very immunocompromised, it can go from the lung to anywhere else in the body, even the liver, even the skin, even is like anywhere, okay? And this is called secondary tuberculosis. So again, tuberculosis is an infection which is caused by Mycobacterium tuberculosis. The main TB prone areas is South Africa and Sub-Saharan Africa, which is, the North Africa. Organisms is aerobic, so it lives in the upper lobes of the lung, and it may result in lobar collapse, bronchiectasis, and pleural effusion and pneumonia, or severe pneumonia, to be honest. Just 1 second, please. Okay, so here, so primary tuberculosis and secondary tuberculosis, we know that primary tuberculosis is a primary infection to the lungs and a small lesion which is called Ghon's focus, which we draw here, and the patient might remain asymptomatic, and secondary tuberculosis, which occur anywhere else in an immunocompromised patient. Presentation is fatigue and weight loss and loss of appetite and night sweats and night fever as well. So chronic productive cough with purulent and blood-stained sputum. So this patient remains as, a very bad source of infection to the community. So tuberculosis is a notifiable disease that you will need to, patient does not need to self-isolate particularly, but needs to be started in treatment. And there is something called DOT, which is direct observational therapy, which we'll discuss at the end. How would you diagnose a patient with tuberculosis? An X-ray is an excellent tool of investigation that can give you the cavitation, which looks like pneumonia. And you can take from the patient some samples, which will be a bit of a lavage, or you can take some sputum from them, which is normally early morning sputum, and then you will examine it. You'll find the acid-fast bacilli, which is a Mycobacterium tuberculosis. A culture, it might take up to 6 weeks. However, we have some screening program in the UK, which happens to all the doctors and anyone who comes from outside the UK to here. And this includes test and this MAN2 test used to be the gold standard for diagnosis. However, recently they are more supporting to IGRA, which is interferon gamma testing, which is used in patients who have Bacillus calmette-Green vaccine. This because MAN2 test may be positive in patients who have had BCG vaccine, which is a false positive. So this test is the best test. Now, management of active tuberculosis, you can give the patient rifampicin, isoniazid, pyrazinamide, ethambutol, and here you have loads of questions about the side effects of these medication. Rifampicin, can it change the color of the urine? It can cause liver toxicity. Isoniazid can cause peripheral neuropathy, and pyrazinamide can cause hyperuricemia and liver toxicity with liver enzymes. Ethambutol can cause retropulpar neuritis, which is some kind of inflammation in the retropulpar area. The transient enlargement in the liver function, maybe rifampicin commonly occurred during the first 2 months of treatment, and it doesn't usually require any kind of intervention. It happens and the patient will be settled after a while. So this is about the tuberculosis, which is the topic which I think like it's being discussed everywhere in medical school and all the subjects. So any questions so far in the last 2 pages?
For TB, its gold standard test is interferon gamma or lavage.
I'm sorry, I didn't get you the question. Can you say again?
What is gold standard test for TB?
I mean, what do you mean by the I mean, what do you mean to diagnose it or
Yes,
to?
yes,
Well,
diagnose it.
there is
Confirmatory.
no single test that can diagnose it, but the culture is the best confirmatory test. So there are certain things that you need to, you know, so for example, let's say, look, let me give you one thing. For a tumor, let's say a brain tumor or wherever, you have many investigations. You have tumor markers, right? You have images, which include CT, MRI, and you can add contrast to both of them. And you have PET CT, for example. And at the end, you have a biopsy. What is the best test to diagnose any tumor in the whole body?
Biopsy.
It's a biopsy. What is the best test to diagnose a, any kind of bacteria? It will be a culture because you can see the bacteria with your own eyes, right? So, however, the culture is not a gold standard test because it takes 4 to 8 weeks to come back, right? So I wouldn't say that this is the best test. It's the confirmatory test. It is the best test to confirm diagnosis. But I think to diagnose, there is no single test that can tell you that this is TB for sure, apart from the culture. But to diagnose, IGRA is good, that can tell you about the disease. X-ray is excellent, that can suggest that this is probably a TB.
Okay, and when we have to do lavage?
So, okay, let me just see, there is someone trying to join from the group. Well, so if you can get, good question. So if you can get some samples, good sputum in the morning, that's fine. But let's say if the patient is bedridden, if the patient is unable to cough, if the patient is like, I mean, for any reason, you're unable to get any sputum from the patient, you can do bronchoalveolar lavage to get the samples, right?
Okay. And if we get sputum, then we should do, culture of this sputum.
You always do culture from the sputum. You do gram stain to give you an idea about the diagnosis, and then you do culture from it.
So blood is not useful for culture.
Why would you do a blood culture for a TB?
Okay, because it is present.
No, I'm asking you,
lung.
why would you do blood culture? Why do you think that blood culture?
Because it is bacteria.
I mean, if you understand the pathophysiology of TB, which I mentioned earlier, is the Ghon's focus. So it's basically a localized infection that happens in the lung, that doesn't, I mean, and encapsulated as well. It's not like bacteremia, it's not like septicemia. So the bacteria is not actually in the blood, it's basically just localized to the lung. But maybe in later stages, it will be disseminated in the blood, but still you wouldn't do blood culture for that, because you know the diagnosis. So blood culture for tuberculosis is not going to add anything to your diagnosis.
Okay, thank you.
No worries. Well, okay, I have some questions for you actually. So can anyone tell me what is the side effect of isoniazide?
Peripheral neuropathy.
Excellent. Anyone else is able to tell me the commonest side effect of ethambutol?
Retrobulbar neuritis.
I hope you're not reading the answers, right? What is the first line of treatment for malaria in a pregnant woman?
Is the permethrin.
Methlucan.
Yeah.
What is the gold standard test for diagnosing malaria?
Thick and thin film.
Sorry?
Blood
Thick and
film.
thin film.
Yeah, blood film. But the one who said thick and thin film is definitely reading, because I never said thick and thin film. I just said blood film. Okay. Well, I'm just kidding, guys. Don't get too sensitive. All right. When does the leptospirosis appear in the serum?
The antibodies
Yes.
after 10 days,
Excellent. Brilliant. And in the urine?
7 to 30 days.
Yeah,
Right?
that's great. That's really good. Excellent. Thank you. What is the best antibiotic to give in a breast abscess?
Flucloxacillin.
Glucose. Why? What is the commonest bacteria that causing it?
Staph aureus.
Okay, and how long will you make the course for? It's not
7 to
written. How long?
7 to 14 days.
7 to 14 days. Excellent. And what if it's not working? What would you do?
A drain, incision and drainage.
Okay, it's gonna be great if we can say, where would you put your incision? I didn't say that obviously, but where would you put your incision? So
Yeah.
let's say, this is a breast, all right? And of a standing lady. So where would you put the incision? Would you put it up there? So in the red area, or just around the nipples, or maybe in the area, or maybe down here?
The most palpable part of the abscess, just above that.
Okay, I'll make the abscess right there. This is the abscess. Where would
So above.
above? Okay, so this is a very tricky one. There are multiple evidence about this, but the best way to put an incision for an abscess drainage is to be with, if you try to imagine, is to be with the gravity. So to drain it, so you need to put the abscess always like the incision is below the breast, just to get it drained by gravity. That's number one. Number two, this is the best area for putting an incision because it's not going to appear in the lady's breast, and there is, I mean, the scar will not be very apparent to her, right? Because the scar in here is not the best. So always put in here. But what is the risks of putting a scar or a wound below the breast? What are the risks of putting the scar in here? So these are one of the flexures of your body. So there is a very high risk of infection. Basically you will need to follow it up and give prophylactic antibiotic to the patient to decrease the risk of infection. All right, good guys, well done. Let's move on to syphilis. Syphilis is basically a dying disease that is being treated by single dose of antibiotics. So we're not going to spend long time on it. So there is 3 different types of syphilis. It's either primary syphilis or secondary features or tertiary features. This happens chronologically. So this happens first, and then probably this one, and then probably this one. So it happens chronologically. So syphilis is caused by Treponema pallidum, all right? And it's basically a painless single ulcer that happens in basically the penis, right? So it's mostly in men. So it's painless single ulcer. This is very important. It's a painless single ulcer, and local non-tender lymphadenopathy happens. It's local and non-tender. So you need to remember that it's single ulcer and lymphadenopathy that is not tender, all right? In women, they are found in the vulva and labia and can be found in the cervix within anal canal as well if they had anal sex. Secondary features, it appears 6 weeks after having the infection, and lesion may be, but it may overlap for several months or take longer. It will be presenting with systemic symptoms, includes fever, lymphadenopathy, and headache and malaise. Generalized polymorphic rash can appear as well on the palms and the papules and large condyloma lata. I mean, it's not, I mean, I wouldn't focus too much on this area. So there is gamma, which is exactly like Ghon's focus. It's a granulomatous lesion, which occur most commonly affects the bone and skin. There is cardiovascular syphilis or neurological syphilis, which causes tabes dorsalis. The patient would be presented to you by ataxia due to affecting with the dorsal root ganglia. The investigation for the syphilis is PCR can diagnose, dark field microscopy can diagnose as well, and there is something called TBHA and VDRL can make a diagnosis from the serology as well from the healed ulcer. Treatment is just one single dose of penicillin or azithromycin. We're not going to focus on this too much for the syphilis. But you need to differentiate syphilis from chlamydia, for example. So chlamydia can cause painless ulcer and also lymphogranuloma venereum as well. We're going to talk about this in detail. So classically found in Africa, India, and the Caribbean, this is syphilis, and outbreaks are usually men having sex with men for gays, and differential diagnosis of rash on the palm is secondary syphilis, hand, foot, mouth syndrome, Kawasaki virus, and this we will see in Pete's notes, and the Rocky Mountain fever, rickettsia, again, this is in Pete's. So this is syphilis. You just need, I mean, just know it, okay? It comes in the exam. I'm not saying it doesn't come, but just know it, like you don't have to spend too much on syphilis. We're going to talk now about the sexually transmitted infection. Sexually transmitted infection, obviously you mentioned syphilis is one of them. However, there are other things as well, and this includes number 1, chlamydia, number 2, gonorrhea, number 3, syphilis, which we mentioned, number 4, chancroid or lymphogranuloma venereum. And also there is genital herpes as well, and Kaposi sarcoma is not actually sexually transmitted. It could be related to HIV, but it's not actually related to the sexually transmitted infections. Well, so chlamydia is not a virus, it's not a bacteria. So it's not a virus and not a bacteria, so it's something in between. It's called chlamydia trachomatis. So in men, if you had chlamydia, it will be probably asymptomatic, but maybe present with dysuria and the urethral discharge. There is a cheesy, like in women, majority asymptomatic, vaginal discharge, intermenstrual bleeding and bleeding after sex, post-coital bleeding, and sometimes dysuria as well. Complication in men, it can cause epididymoorchitis, and this will be discussed in urology. Complication in women, it can cause Fitz-Hugh-Sugar syndrome, and also can cause pelvic inflammatory disease, and lower abdominal pain, deep dyspareunia, cervical motion, tenderness. The diagnostic test could be first catch urine. So this is non-aseptic technique. So you basically find the chlamydia in the urine by just doing microscopic examination. Chlamydia as well is very common to happen on catheters after a long time. Treatment would be doxycycline and azithromycin. Okay, here, can you guys mention to me 3 things from today that we used doxycycline to treat?
Lyme disease.
Sorry?
Lyme disease.
Yeah.
Leptospirosis.
What about brucellosis?
Yeah.
And chlamydia? Well, so treatment would be azithromycin or doxycycline. So again, chlamydia, it's a sexually transmitted infection that happens in males and females. In both of them, it will cause dysuria, and in females, it will cause postcoital bleeding and intermenstrual bleeding and a cheesy vaginal discharge. And in females, there is some serious complication, and this includes pelvic inflammatory disease and lower abdominal pain and dyspareunia and cervical motion tenderness. Treatment is doxycycline and azithromycin. Gonorrhea, which is caused by Neisseria gonorrhea, and the presentation is very similar to chlamydia, but there is usually more symptomatic individuals compared to asymptomatic individuals. So again, it would be dysuria and discharge. Diagnostic test is very similar. Again, you take the urine and you do urine examination, you will find the bacteria. Treatment is ceftriaxone and ciprofloxacin. Okay, ceftriaxone and ciprofloxacin for gonorrhea, because this is a gram-negative bacteria, and ceftriaxone is predominantly gram-negative. Syphilis is, again, we mentioned it, the investigation, we mentioned the investigations, and we mentioned the lymphadenopathy, primary, secondary, and tertiary, and the treatment immobility as a source. Chancroid, Haemophilus ducreyi is the pathogen, which is a bacteria. It will cause erythematous papular lesion that looks like an ulcer that is very painful and usually acquired from abroad. And I don't know why they always mention Thailand. I don't know why in the exam. Ulcers can bleed and ulcers are painful. They are not painless like syphilis, and focus on this. Ulcer can be single or multiple and maybe yellowish or exudate. So again, syphilis is a single ulcer, all right? And it may be painful inguinal lymphadenopathy. If you remember for the syphilis, it's painless lymphadenopathy. So this is the main comparison that you will need to know. Herpes simplex virus. So we mentioned early human herpes 4. Which one was that? Can anybody say?
Mononucleosis.
What's the name of the virus?
Infectious mononucleosis. Epstein-Barr virus.
Excellent. So here we have human herpes virus number 1. It's herpes simplex virus. Okay, and there is number 2 as well. So does anybody know where does number 1 occur mostly, and where does number 2 occur? Which one is genital and which one is oral?
One you said above the waist and 2 below.
Yeah, exactly. So 2 is more likely to be genital, but on 1 more likely to be oral or labial, but both of them can occur anywhere. Okay, but this is more likely to be oral and this is more likely to be genital. The presentation will be flu-like symptoms, and also again, this is exactly like Epstein-Barr virus. It's a dormant virus that remains in your body and we can't really get rid of it. Okay, so it's a flu-like symptoms, vesicles and papules around the genital area, and they burst and form shallow ulcers. So the ulcers here will be small, multiple, and painful. and they cause lymphadenopathy as well. So this urea can be present. You can do a viral culture, you can do a PCR to diagnose, you can do serology to diagnose as well. And the treatment will be oral acyclovir. Let's talk about the role of serology in herpes simplex virus detection. So there is a type-specific serology according to type 1 and type 2 to test you if you are asymptomatic and can distinguish between 1 and 2. Serological tests can take up to 12 weeks to come back, after the primary infection has happened. So if you take the serology, I mean, serology means you're taking them serum, you're taking blood from the patient, you're not taking anything locally, you're not doing a culture, you're not doing a PCR from the local area. So serology takes up to 12 weeks, so it's not effective, so you would have started the treatment already. And useful if recurrence or a typical genitalia happens, negative culture or PCR, so that's the only time when it's useful. Okay, so I think that's it for herpes simplex virus. Kaposi sarcoma. It's a malignant neoplastic lesion abnormally growing in the blood vessels and may begin in more than one place. So it's usually happen in elderly, Jewish or Mediterranean man or young adult man who had an HIV, who was immunocompromised or had AIDS. It's more likely to happen in men than women. And it happens in Caucasians and Mediterraneans and Middle Eastern more. And also it happens in MSM, in men having sex with men or gays, is decreased immunity level like HIV and so on. So these are the risk factors or the types that can happen. The presentation would be some kind of a blackish in color or brown in color, or maybe a bit purple in color. It's papules, so basically it's raised. Lesion can be seen under mucous membranes. So if it mostly the commonest thing is it happens in the mouth. When they open the mouth, you'll find a lot of indurations just below the mucous membrane. It's painless, and lymph nodes might be enlarged, and lesion may involve internal organs like lungs and lymph nodes and GIT. So this is Kaposi sarcoma, and you can see some pictures on the internet for that. So that's Kaposi sarcoma. Any questions so far for the STIs and Kaposi sarcoma?
I have a question about Kaposi. So can you, yes, thank you. So depending what does the type depends on, like what it says, the race and the environment, or it's just that? Those are the types, I mean?
I'm sorry, I didn't understand the question. What do you want about the types again?
Yeah, how do we
Classify it, is that what you're saying? Well, that's actually a good question. I don't really, to be honest, you're right. I think I don't really understand the classifications that we've written here. I don't really. So I mean, the first two is based on environmental factors and geographical factors, and second two is based on immunity and medical things. So my impression is that there are actually two classifications, but I'm sorry, I don't really know what was meant by that. So let me ask. I'll ask the author for the notes to revise that and see if there is anything that we can change it or find the actual classification for it.
Thank you.
Yeah, we'll take that.
I have one question. We can recognize Kaposi sarcoma by induration or by its color. Is it purple in color or?
Well, yeah, this is a good question. So basically, not any induration will look like Kaposi sarcoma. So it's you can think of Kaposi sarcoma. Again, this is a sarcoma. That's a tumor. So biopsy is a. So what you do is.
So any patient with HIV.
Yeah, you have a patient who's elderly or he has HIV, and presented to you with multiple skin lesions that is papular and blotchy and purple and black in color, that is below the mucous membrane, and it is painless. So you think that this might be Kaposi sarcoma. So that doesn't stop here. If you like, this topic is not complete, right? So how to diagnose? So basically you need to exclude the HIV or confirm that the patient has an HIV by doing the HIV tests. And number two, you need to take a biopsy from this sample and establish that the patient doesn't have a tumor or a sarcoma, or does have a tumor or sarcoma in this area. And after doing this, you will start treatment, which is probably a resection or giving some kind of medication, which I don't really know what medication to give for Kaposi sarcoma.
Okay, thank you.
All right, thanks. Tetanus prophylaxis. So this is kind of an important area, to be honest. It's very relevant to the exam questions. So tetanus prophylaxis, it happens at 2 months and 3 months and 4 months and 3 to 5 years and 13 to 18 years. So the following age, I mean, we're going to mention the key part here in tetanus vaccination in this table, but we'll mention everything in detail because this is a very relevant part that comes in the exam. So we need to establish a few things. The following groups of patients with any of who don't need any kind of reinforcing doses. So let's say you have certain patients who had these vaccinations, and then they presented with a wound that you think this wound might be contaminated or not contaminated or whatever, and you think that tetanus might be appropriate for them. There is a certain group that don't need that. So if you have a patient who's above 11 or above, and who his primary course of the vaccine, which is this one, and the last dose was within 10 years, maybe like 8 years ago or 7 years ago, you don't need to give them any kind of a reinforcing dose of tetanus because they had their vaccine already, okay? So if the age is from 5 to 10 and they are still receiving the vaccine and they had the second month and the third month and the fourth month and the 3 to 5 years vaccine, still you don't need to give them any kind of booster dose. If the patient is under 5 years and had his priming course, you don't need to give them vaccine. So if the patient had the vaccine given already, so you don't need to repeat it if they have any kind of contaminated wound because they are vaccinated against this, okay? Well, what is a tetanus-prone wound? It is basically any kind of wound that is contaminated from, so this is basically a deep wound that is contaminated from the environment by any kind of reason, or open fractures or compound fractures, or wound that has any kind of foreign body inside, any kind of foreign body. Doesn't matter if it's a rusted nail or non-rusted nail, doesn't really matter. People who had burns and then they developed sepsis, and certain animal bites can also be prone to tetanus. So these are the wounds that you need to think, does my patient need tetanus or not? So basically you have, again, so the first thing that happens is you have a patient with a wound. So you assess your wound and you think, is it tetanus prone or not tetanus prone? If it is prone, okay, you need to ask the patient or check the patient data. When was the last time they had a vaccine? And check if it was less than 10 years ago, you don't need to give any vaccination, right? And if the patient is one of those groups, you don't need to give any vaccination. Okay, so this is a tetanus prone wound, but there is some kind of high risk wounds, very high risk wounds. So these are the heavy contamination. which is basically by animal fecal matter. Wounds or burns with extensive devitalized tissue. Let's say the patient has degloving of the whole arm, for example, or wounds or burns requiring surgical intervention that is delayed for more than 6 hours. So any burn that is or wound that will have surgery, but the surgery has been delayed for 6 hours, this is a high risk tetanus wound. Okay, so you do your wound assessment. Is it a tetanus prone or is it a high risk? And then you exclude your groups, which are those groups, and then you decide if the patient needs your vaccine or not. So we'll do this in form of questions. Common scenarios regarding tetanus vaccination. Let's start with the first one, and I need one of you to answer with me. So let's say anyone is able to participate. Anyone?
Yes.
Yeah, you have a child who is up to date in his vaccination and schedule, and he has a very clean wound. What would you do? Would you give him a vaccine or not?
No.
No vaccine. So this is basically a child who is less than, let's say, 10 years. So he's from one of the group of exclusion. So to be honest, it doesn't really matter. Since he is in this group of exclusion, it doesn't really matter if it's a clean wound. Doesn't really matter if it's a tetanus prone wound. Doesn't really matter if it's high risk wound. You're not going to give any kind of vaccination, right? Because he's one of the exclusion group, is up to date in his vaccination. Well, another person is able to participate, please. A child who had a primary course, first 3 immunization, which is 2, 3, and 4, okay? But overdue, didn't have the next routine course, okay? So he basically missed one of the doses. You have a clean wound. What would you do in a clean wound?
Vaccinate with the missing dose only.
Okay, sounds good. Or you have a tetanus prone wound. What would you do?
Vaccinate.
And you have a very high risk wound. What would you do?
Oh, I would say vaccinate, but I can read immunoglobulin.
You're not reading, are you?
No, I can. What I mean is, like, I was gonna say vaccinate, but I was able to read immunoglobulin.
Okay, fine. So basically, so the first one, to be honest, does not really need to be vaccinated. For the sake of the wound, it's because it's a clean wound. So the wound itself doesn't need vaccination. But since the patient is here and they missed one dose, you can give them the booster dose, right? The second one is a tetanus prone. So they need vaccination because they need to be vaccinated for the wound and also because they missed a dose. The third one, you have 2 issues here. A patient who missed a dose and his wound is very high risk. So you need to give something to the wound and something to the patient. So the tetanus vaccine is not like treating, is not a treatment, right? That's not a treatment. It's just like to prevent significant complication that will happen later on. It doesn't work actively now. So in this patient who's high risk wound, you need something that works actively now, and that will be the immunoglobulins. All right, let's go to the next one. You have an adult who had a booster in the past 10 years. So this one, I would say he is up to date, right? And he has a clean wound. What would you do in a clean wound?
Nothing.
Nothing. Okay. What would you do in a tetanus prone wound?
Vaccinate. Who had a booster? Don't.
Yeah. What would you do in a high risk tetanus wound?
Don't vaccinate either.
Will you give an immunoglobulin for him or not?
No.
All right, so yeah, that sounds good. Sounds very reasonable. You're not gonna do anything for this patient because he's up to date. This patient was up to date as well, so you're not doing anything for both of them, right? I mean, obviously you're treating the wound. You're not leaving him with the wound, but you're not gonna do anything about the tetanus vaccination. Adult who has not had booster in the past 10 years, and he has a clean wound.
Could it be opportunistic, like the opportunistic booster?
Tetanus prone wound, what would you do?
Tetanus prone, vaccinate.
Vaccinate. And high risk, what would you do?
Vaccinate plus immunoglobulin. Same case scenario as the child, right?
Exactly. So can you tell me, since you're answering everything, can you tell me what is a high risk tetanus wound?
What is what?
A high risk tetanus prone wound.
Well, it will be wound that is dirt contaminated. It would be a wound that in fire burn. I mean, yeah, burn.
Can you read that? It's either an animal or a burn that is delayed for 6 hours from surgery, or a wound that is delayed for 6 hours from surgery. Don't forget what is a high risk wound, because you know the exam question will not tell you that this is a high risk wound. It will tell you you have
That scenario.
yeah, exactly. It will tell you you have a 60-year-old male patient who had a wound that is complicated by animal spores on the road, or he has a compound fracture and presented to you, and you think about giving him tetanus, and the last dose he had was 20 years ago. What would you do? So it's either no action or the vaccine and the immunoglobulin, or the vaccine only. So you need to remember what is a tetanus prone wound and what is a high risk wound. If you are uncertain of the vaccination, you can tell when the patient is vaccinated, deal with them as if they haven't been vaccinated. All right, that's the rule. If you don't know, it didn't happen. Okay, if you don't know, this didn't happen. Okay, so it will be basically the same like the one before it. No, actually, it will be the one like the child. So if it's a clean wound, you will vaccinate because he's not vaccinated to you. If you don't know, it didn't happen. Okay. So tetanus and the rusty nail. So guys, just read that. It's like a story. So just go through it. It's not really relevant. Just read it. Okay. So common vaccinations. So HIV is not really a vaccine. It is a medication that we call post-exposure prophylaxis. So post-exposure prophylaxis usually happen after patient has been exposed to any kind of either like sexual intercourse or maybe needle stick injury that we know for sure that this patient has HIV, and we need to protect this patient from developing HIV. So if the viral load is less than 200 plus antiretroviral therapy for more than 6 months, you can reassure your patient. So you basically take blood sample from them, measure the virus load, and then if they are on retroviral and they have been exposed to a new injury or any kind of so again, just to explain this, so this is not your patient. So this is the one who caused you the infection. So you have two people. One is HIV positive, right? Who is antiretroviral therapy. and who viral load is less than 200. So you need to reassure your patient, so not reassuring the one who has HIV already. And if the patient has more than 1,000 copies, so not the patient, if the person who, well, the source of infection has more than 100 copies, you need to do prophylaxis for 28 days of antiretroviral medication, and this will need to continue for 28 days, and then you will test the patient after 2 months. Post-exposure prophylaxis is required. It should be given immediately for 28 days. It's very effective in the first 72 hours. Don't wait for any kind of serology or blood results. It needs to be started immediately. And the first line is Truvada and raltegravir. Okay. Tetanus, we mentioned everything about tetanus, so there is no need to repeat it. Needle stick injury.
Doctor,
So, yeah.
PrEP is also used for newborn babies coming from HIV mom, or that's a totally different scenario. I can't remember.
So again, what is that again?
On babies that are on newborns from HIV positive moms, does this PrEP also apply? Different.
It's very similar to this scenario. So you consider this as a post-exposure prophylaxis. So if the mom viral load is less than 200 and she's an antiretroviral medication, you don't need to do anything. If she has more than 100 copies, you need to give prophylaxis for 28 days for the newborn. So it's basically the same scenario.
And which is the Truvada, raltegravir? Are they like intramuscular, subdermal? How are they?
I'm not really sure. I know that this one is intramuscular, but I'm not sure about the Truvada.
Yeah, because pinching yourself for 28 days sounds.
Sorry?
It's just like getting a shot for 28 days.
I'm sure that this one is IM, but I'm not sure about Truvada. We can check actually. I will check and I'll let you know probably in the chat later on after the session. I'm not very sure if it comes in different sources, but I know that this one is IM. All right. So I'll check that and I'll let you know. Okay. So tetanus, we explained it, and needle stick injury. There is high risk of HIV and hepatitis B surface antigen and hepatitis C. Test the surgeon for hepatitis B surface antigen. If the surgeon should be offered hepatitis B booster dose, if they can't remember when was the last time. It's basically the same scenario for the tetanus. If the patient considered low risk, there is no post-exposure prophylaxis needed for the HIV, you're basically referred to that again. And the surgeon should return in 6 weeks for full test serology, hepatitis C, and HIV antibodies. If this comes back as negative, the patient initial blood test was also negative, discharge was no further follow-up. Okay, so again, the patient, if your doctor or like a nurse or whoever has got a needle stick injury, they are at risk of developing HIV, HCV, and HPV. You need to test them for all of these. And if the patient was HIV positive, you need to refer to this one, the same scenario. And the surgeon will need to come back in 6 weeks to get full tests again, including hepatitis C and HIV and even hepatitis B as well. If the patient refused to provide samples, you need to make all the tests immediately to the surgeon in 6, 12, and 24 hours. Human bites, and all human bites should be treated with 7-day course of oral co-amoxiclav, right? So oral co-amoxiclav is the first line of treatment. Second line of treatment would be metronidazole or doxycycline, erythromycin, or clarithromycin. So the first line of treatment is co-amoxiclav. Second line is metronidazole and doxycycline or erythromycin or clarithromycin. This has been explained in detail. So we have here a few notes. Would you guys prefer? I mean, we have explained most of the notes apart from one thing down below about the this one, the Ramsay-Hunt syndrome. Would you prefer me explaining all the notes and going through them quickly, or giving you questions from now? Because we are really behind on time.
I'm all right if you explain, but up to the rest.
So you want me to explain the notes? That's what I'm saying.
Like a quick read, because most of this has been covered.
Yeah, I mean, it's most of them has been covered. So for example, we've talked, yeah, so for HIV patients, BCG and yellow fever can be given. BCG cannot be given in any patient who has immunocompromised, and this is because this is a live attenuated bacteria, basically. So the vaccine for yellow fever and the BCG is live attenuated. So obviously this one we haven't mentioned. MMR vaccine should not be given in HIV because, again, this is a live attenuated mumps, measles, and rubella. So yeah, any kind of live attenuated vaccines cannot be given. Yeah.
Regardless.
In age stage 3, in age, sorry?
Yeah, I read that again, yeah. Sorry.
Exactly, in stage 3 it's different, but if the patient is severely immunocompromised, you can't give the live attenuated vaccine. United Kingdom, rabies vaccine is indicated when a person is bitten by a bat, and this is actually common. I've seen this multiple times. I mean, a bat. Patient coming to A&E after being bitten by a bat. Well, follow-up serology for hepatitis B, C, and HIV at 6 and 12 and 24 weeks. Remember that this is if the patient refused to give you the samples. Hepatitis B, so hepatitis B basically has 3 capsules around it. So it's a virus, it's a DNA virus, as you know, and has 3 capsules around it. So there is a core antigen, and there is an envelope antigen, and lastly, there is a surface antigen, all right? So we basically, our tests mainly is about the surface. So hepatitis B surface antigen positive means that the patient has the infection now or has been infected for a long time. So it's either acute or chronic. So if the antigen is positive and the envelope is positive, the envelope means he's infective, all right? So mean that the patient is very highly infectious at the moment. If the patient starts to have antibodies to the surface antigen alone, that means it's a recent infection, or antibodies to the core antigen, which is inside, that means it's a chronic or a past infection, all right? So surface antigen means the patient has infection now, or the infection has been there for a while. Surface antibody mean the patient had a vaccine. Surface antigen and envelope and antigen positive, that means it's highly infectious. And anti-core means it's a past infection. That's a scheme. If you like it, know it. If you don't, just leave it. So you can just read that scheme to remind you. Positive hepatitis C, HCV antibody reactive or RNA detected. You basically do a PCR for that. Active TB, productive cough, so it's an acid-fast bacilli. We mentioned that. We mentioned the bronchoalveolar lavage. We mentioned them in 2 tests. We mentioned the difference between a painless and a painful ulcer. for the primary syphilis and the Haemophilus ducreyi, and multiple painful ulcers. We mentioned that as well. It's an herpes simplex virus. Multiple painless ulcer. It's a human papilloma virus, mostly in females. We mentioned the DOT. It's a directly observed therapy. So basically, you need to treat the patient under supervision. You don't give the patient medication. You bring them to the hospital and give them the medication, and then they can be discharged. High-risk patients with known or suspected TB should be isolated in a negative pressure room. This is only high-risk. We don't need to isolate all the patient for TB, but if the patient is in the hospital, they need to be in a separate room because they'll be infectious to the others. But the patients with TB don't need to self as long as they are on treatment. If they are not in treatment, that's basically it. Sorry?
Don't remember where, I think I read it in the first aid. It says that in negative pressure room of UV light, is that correct? Or that?
No, that's a different thing. I think you're talking about preeclampsia.
Okay.
Yeah. It doesn't have to be in blue light. High-risk TB patients, certain countries and live close with someone who has active TB, homeless or immunocompromised. I think this is something that you can know. Diseases related to area, it's not necessarily related to it, but remember that for the exam, just read it. So malaria is from Africa, dengue fever from Far East Asia, and so on. Dengue fever is generalized rash, biphasic fever, and retroorbital pain. Okay, so that's something you don't need to read the dengue fever in detail, but at least know this one. Typhoid, there is something called Faggot signs. It's a high fever and the bradycardia. So typhoid is common for bradycardia, severe headache and coughing and so on. Diphtheria is a disease that died like 50 years ago. It's not present anymore. Upper respiratory tract infection, cervical lymphadenopathy, it's infectious mononucleosis, we mentioned that. Tonsils with white exudate, probably an infectious mononucleosis, probably. It's not necessarily. Tonsils with gray exudate, it's a diphtheria or pseudomembrane. Parotid enlargement, it's mumps. Herpesvirus 4, it's, if you remember, we mentioned that. Herpesvirus 8, yeah, we missed this one. It's a Kaposi sarcoma. Okay. Most common cause of laryngitis is common cold. So guys, as you can see, we mentioned like most of the things from here. You know the pole bundle test, you know the Kessing disease, we mentioned there. Travel to Africa, dark urine, hematopium, most probably, doesn't mean it's necessarily this. Travel to Africa, hepatomegaly, schistosoma. Travel to Africa, dark urine, hepatomegaly, malaria. Okay, so again, same things. People with chickenpox and mumps, both self-limiting viral treatment. Immunocompromised patients, like asymptomatic give immunoglobulins, symptomatic give acyclovir. Right, that's the one I was talking about. You need to remember that. If CD4, from this number, there is no risk of infection. 500, 200, Kaposi sarcoma is one of them. Streptococcus pneumoniae. Less than 200, pneumocystis is a risk, pneumocystis pneumonia. Less than 100 is toxoplasmosis. 550 is cytomegalovirus and Mycobacterium avium. I think this one is important. You need to remember it. Okay. So the mother is encouraged to continue breastfeeding with all conditions except HIV and some cases of breast abscess. We mentioned this. HIV because, obviously the, and actually, to be honest, there is some research recently that women with HIV can still breastfeed, but we're not gonna go into that. Hepatitis C, they can still breastfeed unless there is some kind of cracks in skin. Yeah. So, I mean, same things. Read these risks: 0.3 HIV, 3% hepatitis C, 30% hepatitis B. That is the risk of the infection from a needle. Neutropenic sepsis usually happens with patients on chemotherapy. Antibiotic must be administered immediately because it's a sepsis. Peptaz is the treatment, piperacillin and tazobactam. If it's still febrile after 48 hours, you need to escalate to meropenem. If it's still responding after 46 hours, investigate for fungal infection or the antifungal. Neck stiffness, just read the differential diagnosis. So neck stiffness is any kind that causes meningeal irritation. So subarachnoid node hemorrhage is one, migraine is one, meningitis is one, malaria is the last one. That's a treatment for MRCA, mupirocin, nasal ointment. MRSA treatment of a choice is vancomycin, teicoplanin, if they are having it in the GAT. Ramsay-Hunt syndrome causes a facial nerve palsy. So the patient will have pain, unsteady gait, red rash, palsy of the seventh nerve, loss of hearing, and the exception, there is not always a rash. So, but rash could be one. Treatment will be rapid antiviral, acyclovir, steroids for the nerve palsy, and eye care, right? Well, we can talk about angular cheilitis. It's redness and pressuring and sore of the mouth. Older age, B12 deficiency is one of them, and iron deficiency anemia is also one of them. Screening after anal sex, if the man is receptive for anal intercourse, you can take a rectal swab to rule out chlamydia and Neisseria gonorrhea. With inserted penile sexual contact, you take urethral swabs as well for the first void, at the beginning of passing urine. And the other screening includes HIV and hepatitis B. Yeah, if the patient has pneumocystis, the treatment is co-trimoxazole, which is trimethoprim. And CD4, if less than 50, Mycobacterium avium, it's an upper respiratory tract infection. Treatment for upper respiratory tract infection, most of the times it is azithromycin. All right, I think that's it. I have some questions, and then we have the epidemiology. We'll take a break with the questions, and then.
Sorry.
Sorry?
Will COVID be assessed in PLAB 1?
I didn't get that. What is the question again?
Will COVID be shown in ask in PLAB 1?
Well, it could be, to be honest. It could be. And I think it's worth asking the author of the notes to include COVID topic, like a small topic in PLAB 1. But I haven't seen any question about COVID recently. So I'm not very sure if they will bring it, but it's one of the medical topics that we need to cover anyway. So probably I will ask the author of the notes to add probably a topic about COVID, and we might make you a short video about it, just in case if it came in the exam.
That would be great.
Yeah, I'll ask him, sure. All right, so guys, I'll give you 5 minutes break, and then we can come back for doing some questions and then explaining the epidemiology. All right, just 5 minutes break. So the time now is 17:15, so it's 5:15. So I'll see you in 20+5, so in exactly 5 minutes. Thank you. All right. Hello, everyone, again. So we're going to continue now the questions, and then we'll explain the epidemiology quickly. So question one, I need you to take you and in the same sequence. So can we start with Abigail again? Hello, Abigail, can you start, please?
A 25-year-old enters the emergency department after an altercation. He explains that he got into a fight with another person while drunk in a pub. Although his memory is hazy, he remembers being punched in the face and being beaten in the hand. On examination, there is extensive bruising around the left orbit and a bite mark on the lateral surface of the left hand. Which of the following antibiotics should be prescribed for the bite? Coamoxiclav.
Okay, so it's coamoxiclav. That's your answer, right?
Yeah.
Why don't you think that it is metronidazole and clarithromycin?
Because that would be only if he's allergic to, or
Yeah, great.
and
So
there
yeah,
you can say that.
yeah. So it will be coamoxiclav. Yeah, right. I don't think that I need to explain this. So, but what we can do actually is here. So we had the human bites, and it commonly causes multi-microbial infection, Streptococcus, Staph aureus, Legionella, and these kind of bacteria. You don't need to know all of that. You just need to know that the coamoxiclav is the first line of treatment. And here, this is an animal bite. Again, coamoxiclav is the first line of treatment for animal bite, and cleans the wound. Puncture wounds should not be sutured or closed unless for osmosis risk. So you leave the wound open for the patients with animal bites. If you want to know that organism, it's Pasteurella maltosida. Is the commonest organism for animal bites. But it's very easy for you now that the coamoxiclav is the first line of treatment for both animal and human bites. Well, I'm sorry, this one is answered. So anyone is able to read, and I will give you the choices. Next one. The next is for Hash.
Yes.
Can you read this, please?
The phlebotomist in the GP surgery sustains a middle stick injury while taking blood from a patient who is known to be HIV patient. Following through washing of the wound, what is the most appropriate management?
What would you do in this patient?
Mm,
Do you want me to give you a choice? Because I mean, it's answered. So I don't want to show you the answer, you know?
First, obviously, I check if it is really HIV positive patient, then I go for 28 days PEP post-exposure prophylaxis after washing my hand and everything.
Yeah, you're right. So yeah, you will go for the post-exposure prophylaxis for this patient because it's confirmed that he is HIV positive. But here they didn't specify. Let's say if it's HIV positive, but he is the viral load is less than 200, and he is an antiretroviral. So you want to start, but since they didn't mention it, you would assume that his HIV positive was higher viral load. Okay. Next is this one. Who's able to help me with the answer? Next.
A 20-year-old student presents complaining of multiple painful ulcers on the shaft of his penis. He tells you he has had a new sexual partner recently, but she has not reported any symptoms. He feels generally unwell and had tender enlarged inguinal lymph nodes bilaterally. He denies urethral discharge or dysuria. And what is the most likely diagnosis? Multiple painful ulcer. So it's the lymphogranuloma venerum.
Can you think again?
Because tender, enlarged inguinal lymph node.
Yeah, you're right, but can you think again? Do you want to think again about it? Oh,
We should see if it is single or multiple. Then we should choose the answer, I think.
sorry?
First we see it is single or multiple.
Yeah, in syphilis is most likely the single. And
So syphilis it's never syphilis because syphilis is
Painless.
painless and single and painless lymph nodes as well, right? So,
so it's
and
lymphogranuloma
what do you think about herpes simplex?
herpes simplex.
There's multiple painful ulcers with tender enlarged lymph nodes as well. That's my opinion. And let's see the answer. Yeah, I think it's syphilis. And let's see the explanation for why it's not lymphogranuloma venereum. Because simply LGV causes painless genital ulcer, right? It's not painful ulcers. And lymphogranuloma venereum, it's not going to be multiple. It could be 2 or 3 ulcers, but it's not like as multiple as the herpes virus. So herpes simplex is, you can say, is the most painful one. Okay, lymphogranuloma, I would say it can cause discomfort, but it's not painful like herpes simplex
It's
virus.
painless.
Sorry.
Lymphoma granulum is painless, and Ducra is painful. Single ulcer.
Yeah, but I mean, Ducrea is not simple. It's not single ulcer, right? Mofus Ducrea
Then
is not.
what is it is not multiple.
So again, what's the question again?
Ducra is a painful
Can you read
single
Ducrea here?
or
So-
multiple.
So those are 2 different diseases, right? Those are
Yes.
2 different diseases.
Okay.
The chancroid or Haemophilus ducreae, it causes painful genital ulcers with unilateral painful inguinal lymph nodes. They also typically sharply defined ridged undermined borders. So if this multiple or single, it is not single. It's not single. Okay, so it's many ulcers, but not as many as herpes simplex. Herpes simplex is very huge amount of ulcers. So like many ulcers, right? Lymphogranuloma venereum, this is caused by Chlamydia trachomatis, and it is painless ulcer. Okay. I mean, it's not actually an ulcer from the start. It's a pustule, which means like small vesicle, and then the top will be atrophied like that, and it will form an ulcer at the end. Okay. So LGV is painless ulcer. And most of the time I wouldn't say it's single like syphilis, but it is not multiple neither. So it's just a few ulcers, maybe 1, 2, 3. But for herpes simplex virus, it's many ulcers. Right? Is that clear? Do you think it's clear now?
Yes.
So herpes simplex is the answer. Next, who is next? Who's next? Kanis Fatima?
Yes,
Any answer?
a 33-year-old woman attends the emergency department after being bitten on the hand by her neighbor's cat whilst house sitting. She reports mild pain and swelling over the bite and denies fever. On examination, there is a small puncture mark over the palm of her left hand. There is mild surrounding erythema, but no visible purulent discharge. What is the most appropriate treatment for this patient? Is the co-amoxiclav?
Yeah, this is the first line of treatment, like we mentioned earlier. What would you do for the puncture mark?
Clean it first.
A big nothing, okay? You just leave it. Don't touch it. All right? So the answer is co-amoxiclav. Well done. Who's next?
Me.
Yeah, can you go?
Old woman presents to her GP with a 2-week history of vaginal discharge that is pale and homogeneous in color. The discharge is offensive and not causing itching or irritation. Examination reveals no inflammation of the cervix or vagina, and the discharge has a pH of 6.3. Sample of the discharge is taken. What is the most likely finding or analysis of the discharge sample? I would think yeast cells with IFA.
Sorry, again, what's that?
I'm thinking about since it said that it's pale and homogeneous in color, and it isn't causing itching or irritation. I would think it's lactobacilli.
What is the lactobacilli?
It's the normal flora of the vagina.
Okay, can you think again about this?
Yes. This is pale and homogeneous. So that, so if it was a candida infection, it would be like with little lumps, right? And it would be itchy. So that will rule out yeast cells with IFA, sorry.
Yeah.
Then I could
What's
think
your diagnosis? What's your diagnosis in this one?
I think she has oh, sorry, I know in my language. It's a pelvic inflammatory disease, could be.
Well,
Is it
I think,
bacterial vaginosis?
I mean, this is not a very easy question, to be honest. So what is the pH for this patient? It is 6.3. And the discharge is offensive,
Excuse me, doctor,
not
is it
causing itching or
bacterial
irritation.
vaginosis?
Excellent. This is bacterial vaginosis. But
Because
what would
there's
you
a high
choose?
pH and it's a highly like offensively smelling
Yeah.
discharge.
What would you choose from this? What is bacterial vaginosis?
Is it a gram positive or negative? So the normal flora is lactobacilli, like the other doctor said.
Yeah. So I
But-
was just like, I was just trying to make you guys think. Lactobacilli is the right answer, but I was just trying to make you, get you confused about the gram positive and the negative, which is positive and which is negative. So Gardnerella vaginalis is a strictly aerobic, positive, gram positive bacteria, right? So it's strictly or predominantly anaerobic bacteria is gram positive. So this is excellent, but bacterial vaginosis, that's the answer. So the causative organism is Gardnerella vaginalis. It's anaerobic organism, and this leads to lactic acid producing anaerobic lactobacilli, resulting into raised pH. This is not a sexually transmitted infection exclusively in sexually active women. It's fishy and offensive, asymptomatic in 50%. There is something called Amstel criteria for diagnosis of PEV, and this is what your colleague just said. Okay, well, it's a thin, homogeneous discharge that is offensive with pH higher than 4, and positive with this is the diagnosis. Treatment is metronidazole for 5 to 7 days, and yeah, that's it. Next question. Who's gonna answer this?
A 30-year-old man attends his friend's stag to where they go to eat at an all-you-can-eat buffet. 7 plates in, he finally feels satiated and they eventually head over to the local casino. 2 hours after finishing the meal, he is at a poker tournament. He suddenly feels unwell and begins to profuse vomit all over the table. He goes home and through the night the vomit subsides. The next day he is feeling better, grateful he did not have diarrhea. What is a likely organism? Um, in every dinner, basically most cases of food poisoning that involves staph aureus. But in this case, he goes home and vomiting subsides, and now he's feeling better. So that is confusional for
Yeah,
me.
it's not confusing
But
at all. It's Staph aureus, like you said, mate. It's a Staph aureus, definitely. So this is a pre-rapid course, and the patient is improved significantly after that. So this looks like a toxin rather than a bacteria. It's not a bacteria.
okay,
So yeah, so Staph aureus is one of the things that works with the toxin and not the bacteria, right?
Yes.
So it's going to be Staph aureus.
Sorry,
Very-
doctor, the bacterial vaginosis question, what options did it have? It did not have, can I have a look at it again, please? Okay, thank you.
Make sense?
Yeah.
All right. Great. Next question. Who's going to take it? I don't think that I have a next question for you. So that was the last question. So let's go for the epidemiology, 4 pages only. So I was just going to mention a few things to you in epidemiology. There's something is called an absolute risk. So absolute risk is of a disease is his risk factor of developing this disease over a time period. So let's say there is a 1% risk of people who lives in South Korea to get diabetes between 20 and 30 years. That means 1 every 100 patients can get this disease. So this is called the absolute risk. And there is a way to calculate the absolute risk. So you're basically measuring the number of people who are deceased over the number of the population or the certain group. Okay, so let's say you're trying to measure the risk factor of COVID-19, the absolute risk of COVID-19 in the UK. So you basically measure all the population who had COVID vaccine over all the population, and that gives you the absolute risk. Okay, it can be expressed in multiple ways. You can say 1 in 10, you can say 0.1, you can say 10% risk. All right, so it's basically the same thing. There is something called relative risk. Relative risk, it's used when you are comparing between two groups. So let's say you have a group of people who are who have like a certain disease, and you have a group of other people who have, who don't have the disease. Okay, so you have two different groups. Group is called the disease people, and the other group is called the control group. Okay, or let's not say a disease. Let me give you the example in a better way. So let's say you are introducing a new treatment or something like that, and you need to know the absolute risk or the relative risk for this. So you have people who you are introduced the new treatment for, and you have a control group that you didn't introduce anything. Or we can use it like we did before, the diseased people or the control group. It's called like that. So the absolute risk in the diseased people means the number of the diseased people over the complete number, or the total number, or the absolute risk of the new treatment is the number of people who receive the new treatment and who have the disease over the complete number, and the total number. The control group is the number of people who have certain disease or the same disease over the complete number, the total number of this. But the relative risk will be the division of both of them. So let's read the example here. Consider the risk of blindness in a patient with diabetes over a 5-year period. So when we say the risk of blindness is 4% in a group of patients treated conventionally, which means, let's say, treating with just the anti-diabetic medication, and the absolute risk, again, is 3% in patients who are treated with a new drug. So again, this is the example that we have here. We're treating diabetes. So we're treating diabetes by a new way, or let's say the blindness in diabetes with a new way and a conventional way. And we need to compare which is better. Is it the new way or the old way or the conventional way? So the conventional way is our control group, because this is what we know, right? And this is what we want to know. Okay, so the relative risk will be what you want to know. So the exposed or the new over the control. Okay, so the absolute risk here, or in the exposed people for the new drug, was 3. Okay, over the control was 4. So it's gonna be 75% or 0.75. Okay, so relative difference, a new drug reduces the risk of blindness by a quarter, if you can imagine that. So the risk of blindness here was 4, but now it's 3. So the new drug is better than the old drug. This is how we do the exam. So a relative risk less than 1 means the event is less likely to occur in experimental group than in control group, which means that it's better to use the new one. If it's more than 1, so let's say the relative risk here was 5 instead of 4. So it will make it different. So it will tell you that the control group is better, continue with the old medication. So absolute risk in the disease in exposed, and absolute risk of the disease in unexposed is the relative risk. These are some definitions. Incidence, it's the number of the new cases over the population at risk. So let's say for COVID-19, what is the incidence on COVID-19 in the UK? So who are the population at risk? It's basically all UK. So it's all the population at risk. And what are the number of the new cases? We have, like, let's say 2 million cases. So 2 million over the total population. So this is the incidence. It will tell you how prevalent, the incidence of the COVID-19 in the UK. Prevalence means it's the number of the new and old cases. Okay. So by the way, incidence is calculated over a certain time. So it would say the incidence this month is like this, like let's say 20%. This is the number of the new cases only. But prevalence, it tells you how many of the population have the disease, like the percentage of the population who had or have the disease. Okay. So it's the number of the new and old cases over the total number of the population at risk. We define the absolute risk and we define the relative risk. What is the absolute risk reduction? So we just like minus the risk control, minus the risk test or the risk new or the risk, call it whatever you want, okay, exposed or whatever. So basically in our example of that one, the absolute risk reduction was 1. So you are reducing the number of cases by 1 case, all right? The relative risk reduction is 1 minus relative risk, which means quarter in our example, right? It was 0.25 because it's 1 minus the relative risk. Number needed to treat. It's 1 divided by absolute risk reduction. What is this? What is number needed to treat? It's the number that you need to treat to reduce the risk by the relative risk. So for example, we said here the absolute risk reduction was 1. So we're gonna reduce the risk of, for the new treatment, we will save 1 patient, but how many patients you need to treat until you're able to save 1 patient? So it will be 1 over the absolute risk reduction. So for that 1 that we've did, so the absolute risk reduction was the control, which is control was 4 minus absolute risk in the test, which was 3, so it was 1. So 1 divided by 9, you need to treat 1 patient and it will be saved, all right? The primary attack rate, its number of infected people over the number of total population, is basically like prevalence. That's the primary attack rate. Secondary attack rate, number of secondary cases over the number of people in group minus number of the primary cases. Well, we're gonna speak in detail about sensitivity and the specificity in here, okay? What I would like to say, sensitivity equals rule N, specificity equals rule out. Okay, let's read that. So there is some words that you need to familiarize yourself with, for example, like true. What is true positive? True positive means that you have the disease. What is true negative means that you don't have the disease, right? What is false? False positive means you don't have the disease. False negative means you have the disease, right? You need to familiarize yourself with these words. So, true positive test. So if the test is positive, it could be either true positive or false positive. True positive, the disease is present. False positive, the disease is absent. If the test is negative, means it's false negative, but the disease is present, or true negative, but the disease is absent. Okay. So we mentioned early sensitivity. You are ruling in or out. Sensitivity, it's rule in. It's a test that is able to rule in. It's a test that is diagnostic. Okay. So how would you calculate the ruling in? Ruling in means the disease is present, right? So it's basically the number of true positive over the total number who have the disease. The number of true positive over the total number who have the disease. So you basically say true positive over who have the disease, true positive plus false negative. And it will tell you how sensitive this test. So for example, if we told you that we've made a new test that is called Ball panel test, that is able to diagnose that disease. And we have tested this on 100 patients in total, okay? Well, like 30 of them were true positive. And let's say the 70 of them were false negative. So what would be the sensitivity of this test? It would be 30%. So it's a very bad test. Okay, sensitivity is to ability to diagnose. Well, specificity is the ability to rule out. Rule out means disease absent. So you go here, disease absent, true, all absent. Means it's gonna be D, which is the true negative over all the people that don't have the disease. So this is the specificity to rule out. So if you know it this way, you will never forget it. So it's rule in and rule out. Okay. And the true is always like higher. So true will be on the top. Okay. Positive predictive value. Positive predictive value. It's your ability to predict that the positive will be right or wrong. So positive predictive value, you go to the test positive, and then you go on this line. Because I mean those two things is telling you that the is basically all the positive. So we need to measure if this value, like how valuable is this, how accurate is this. So positive predictive value would be the true positive, which the true is always higher, over all positives. That tells you positive predictive value. Okay. So a proportion is positives that are really like true positives. Okay. So the positive predictive value of this test is like 30%. That means it's not very good. Negative predictive value, it's the number of true negatives in all the negatives. Number of true negatives in all the negatives. All right. Accuracy of a test is the probability that is a patient will be correctly classified. So means we need to measure the true over the whole number. The true over the whole number. So you need to measure the true positive and the true negative over the whole number. So you're assessing the accuracy of this patient, of this test, sorry. So is that clear? In this area, you can have, I would say, 1 million questions. It can give you a scenario. So we had this new test, we would have done it on 200 patients, like 30 of them were positive, but turned out that they don't have the disease. So this is false positive. And the 50 of them were positive, and at the end they had the disease. That means you're true positive. And the rest, I mean, it's gonna like give you examples and then divide it, and it will ask you what is the sensitivity. So you know, sensitivity is ruling in. So we're talking about true positives in top over true positive plus false negative, right? Specificity is ruling out. So we're talking about diseases absent. So we're talking about true on top. So true negative over true negative plus false positive, right? It's gonna ask you what is the positive predictive value. And positive predictive value, we're dealing only with positives. So the true is on top. So true positive over all positives. Negative predictive value, we're doing, when it says negative, we're dealing with only negatives. So negative predictive value is true on top, true negative over true negative plus false negative. Okay. Well, accuracy, we mentioned it. Here we have a few things about randomized controlled trials. So studies are either interventional or observational. And observational could be prospective, snapshot, or retrospective. Retrospective, you're going back. Prospective, you're going forward. So first ask yourself, is this study is observational or interventional? Interventional, you're doing something, you're actively changing thing. Or observational, you're just like collecting data and counting. If interventional, it's most of the time it's randomized controlled trial. If it's observational, it could be either prospective, which is going to happen in the future, or snapshot, which is cross-sectional study, is happening now, or retrospective, to look backward, which is a disease, begin with the disease or the exposure risk. So this is gonna give you the examples, and you can just read it for a few examples on the studies that can be done. Okay. So let's read these notes quickly. So confidence level is a probability that the value of a parameter falls within a specified range values. So if you have a study that has been conducted and showed that 29 post-MI patients needed to be treated with aspirin to prevent just one myocardial infarction. So the 95% confidence interval is 20 to 38. What is the correct interpretation of this data? So we're saying here, what is the number needed to treat to prevent one with aspirin, number needed to treat with aspirin to prevent just one MI to happen. So the number of patients that we need to treat with aspirin to prevent one MI will be in this confidence level, which is between 20 and 38, okay? So this is a 95% confidence interval. So instead of just saying, you need to treat 29 patients, right? To prevent one case, we're just giving you an interval. You need to treat 20 to 38 to prevent one case. The middle point of number set is called median. So median is the middle point of number set, and mean means the sum of all the numbers divided by the amount. So meaning 40, 10, 20, 30, 40. Rearrange, you need to make it arrange. So it's 10, 20, 30, 40, 40. The median here is the thing that is in the middle, which is 30. That's explaining it very simply. But the mean, it means you're counting all of them and dividing them by their amount. So it's going to be 40 plus 10 plus 20 plus 30 plus 40 divided by 5. It's going to give you the mean, all right? The value that occurs most often, least affected by outliers, is called the mode. So it's the least value that happen. A measure of spread or dispersion, set observation calculated. There is something called the standard deviation. It means a measure of the spread or dispersion of an observation. So I mean, you're basically standard deviation. It's the average difference from the mean value in a sample. I mean, it can be. I'm sorry, guys, I can't really explain what is the standard deviation, but it's no, I'm sorry. I think I'll need to repeat that to you. Probably I will leave you a video on the topic, because I think standard deviation is something that is bigger than this line. The chi-square score, it's a test for association between two categorical values. For example, for the sex, you have male and females, and smoking habit, you have a smoker and non-smoker. This is something called the chi-square score. So it's tests for association between two categorical values. So you're basically measuring how likely a male to be smoking versus how likely a female to be smoking. Well, so breakdown is okay, shorter studies. Acceptable dropout rate between groups is considered to be less than 15%. What does it mean? So the journals will accept the dropout in certain studies if it's less than 15% of the participants in this study. Null hypothesis, if you want to show that a new drug works, the null hypothesis will be the drug does not work. The opposite of what you hope to show is called null hypothesis. Systematic review, we mentioned looking at one topic and trying to suggest solutions. So basically in systematic review, you have a question and then you start developing, collecting all the data that is available on the journals, and then try to find a solution from all these data and present it. A case report, if you have a case that is very rare and didn't happen before, you can report it and post it in a journal just to let the, if you have like a new treatment that you provided for a certain condition and you think that this treatment works, you can report it and let the people know about it, or the doctors know about it. Meta-analysis, it gathers all the relevant studies and compares results to have one large. So you basically, in meta-analysis, you get all the available data and you start comparing between them until, after comparing these data, until the colleagues that have compared this and this and this, and I think the results will be this and this. Well, number needed to treat, the number of patients you need to treat using an intervention. I think we explained that. So let me give you an example. For example, if 100 post-operative patients had received low molecular weight heparin to prevent just one DVT, then the number needed to treat to prevent one DVT is 100, basically. Yeah, so it's basically the same thing. Number needed to treat is the number that you need to treat to prevent one case of a certain condition. All right, so that was the epidemiology. I think the main thing in epidemiology is this page. This page is the most important. You need to know it by heart. The other areas, I think they should be okay in the exam. You only have like 1 or 2 questions in the exam for the epidemiology. Well, we're done for today. Do you guys have any questions before I go?
No, doctor, thank you very much.
Thank you. So I will send the feedback now on the group. So please fill the feedback and say whatever you think. So I will probably improve next time. So I have 2 answers for you. I'll answer 2 questions for you next time. It's the standard deviation. I'll just need to read more about it. And there was 1 question from the infection that I will need to read more about it. Okay.
Yes.
All right. Thank you very much. I'll see you next time then.